distance yourself, you got it.
I do.
Okay, you may keep yourself comfortable. You can lower your mask if you're more comfortable. It's up to you. Okay? Okay, I need you to state your name for the record. You got that aerial mic there in front of you?
Okay.
State your name for the record and spell your name so that my court reporter can get used to your voice.
Sure. David Ralston, D-A-V-I-D, Ralston, R-A-L-S-T-O-N.
Can you all hear him?
Yes.
Madam Court Reporter? Okay, Mr. Zion.
Thank you. Can you tell the ladies and gentlemen of the jury what it is you do for a living?
I am an ICU and pulmonary physician and sleep physician at Mount Carmel.
And how long have you been so employed?
Since 1997 with Mount Carmel.
What type of education, starting with college, did you need to do to become what you do today?
I went to college at Miami University. I then went to Ohio State Medical School. I then went into an internal medicine pediatric residency program for 4 years. And then I went to a fellowship in pulmonary critical care for 3 more years.
So that we could give you some so that you could give them some reference how long you've been doing that. What year did you graduate medical school?
1990, I'm sorry, 1990.
All right. And then you were an MD at that point?
Yes, sir.
Licensed to practice in the state of Ohio?
With limitations, being a resident, yes.
Okay, so 32 years ago?
Yes, I guess so, yes, sir.
32 years you've been a doctor or graduated medical school? So what was your first residency in?
In 1990 through 94, I went into internal medicine pediatric residency, where I was eligible to be board certified in internal medicine and pediatrics.
And did you become board certified in either one of those areas?
I became board certified in internal medicine. I was wanting to be a family doctor, but then I fell in love with pulmonary and critical care medicine, so I did not become board certified in pediatrics.
Did you take any additional training or classes in critical care or pulmonary medicine?
After the residency, I had to do a 3-year fellowship in pulmonary and critical care medicine from 1994 through 1997.
Tell us what pulmonary care medicine, pulmonary, what does that word mean? What are we referring to when we say pulmonary?
Sure, it involves the treatment for patients with lung issues in general.
Okay. And critical care, pulmonary critical care. Describe to them what that involves, what a pulmonary critical care doctor does, and what you were trained to do.
Sure. A critical care physician is responsible for taking care of very sick patients in the ICU. Usually these patients are on the ventilator, and our role is to work with the patients to put them on life support, and then eventually try to get them off life support once their disease process is hopefully improved.
And you got that board certification in 1994?
I got that board certification, I think, in 1997.
You started in 94, I think you said.
Yeah, 94, yes.
Okay, so in 1997, what do you do once you're board certified in pulmonary critical care medicine?
I joined Mount Carmel at that point on their private practice group at that point.
Can you describe what that means and what you're doing on a daily basis then in 1997?
Sure. Basically, we would see, it would vary on a weekly basis. We'd have weekly rotations. I would work in the office for 1 week, seeing outpatients, patients with lung problems in the office. I would then rotate into the ICU for usually a week at a time. And then I would also see patients in the hospital on the floors with lung problems in general as well, too.
So you're taking care of people in like an office setting, like I have lung problems, I go to you, call up, make an appointment, and you look at me and you're examining at the office.
Yes, sir.
And then you're also seeing people in the ICU, those would be generally people on ventilators?
Yes, in general, the very sick patients in general, yes, sir.
But then you're also walking to the other floors that say, I'm not sick enough to be in the ICU, but I'm having breathing problems. They might call Dr. Ralston in to see what's up with my lungs.
Yes, sir, as a consultant.
Okay. So how long did you do that That started in 97, so that's 25 years ago?
Yes, sir.
How long are you doing that?
I'm still doing that today. Yes, sir.
Okay, so you've done this for 25 years.
Yes, sir.
Now, just to be clear, are you an employee of the hospital itself?
I was not an employee initially. For several years, I was in private practice, but over the past, I think it's about 5 years or so that, yes, I became part of the Mount Carmel Medical Group, which is the physician component of hospital physicians, basically.
Okay. And the company you work for, is it wholly owned by Mount Carmel then?
I'm not sure.
Fair enough. Fair enough. But you work for Mount Carmel, but you're not like exactly an employee of Mount Carmel. There's a company there.
Yes, that's correct.
Okay. And does your company manage the ICU?
We're consultants in the ICU, yes.
All right. And back in the relevant time frames, 2013 to 2018, what, if any, responsibilities did you have regarding the management of the intensive care unit at Mount Carmel West?
I was the medical ICU director at that point.
So tell the folks what the medical ICU director does and what your responsibilities were on a day-to-day basis.
Sure. It's not necessarily a day-to-day basis, but it's more administrative in general. They would ask my opinion about a new ventilator of some sort, a new defibrillator to shock patients' hearts, to report to all the governing bodies, for example, issues with infections, secondary infections, things like that.
Okay. Did you have any other administrative duties as far as scheduling, things like that?
No. No, sir.
Okay. Tell us prior to 2013, what, if any, doctors were on the night shift at the ICU?
Sure. At the time, Mount Carmel was a teaching program, so we had young physicians in their internal medicine residency at that point. They were in training, and so they would be responsible for the care of the patients at night with myself and my partners readily available by phone if any issues, or even to come in if necessary.
Were you actually physically at the hospital, you or your partners?
No, sir.
And residents, those are the folks that have graduated medical school and are still training?
Yes, sir.
All right, so they're still kind of student doctors at this point?
Yes, sir.
Okay. So at some point, did that change regarding the coverage of the nighttime ICU?
Yes, the residency program at that point, because of some of the work hour shift in thinking, working hours, not want to work them too long, they decided not to provide ICU coverage at night with the residents at that point.
What, if any, change occurred to your knowledge?
At that point, you needed to have physicians at bedside at night, so therefore 2 physicians were hired to provide the nighttime ICU coverage.
Do you recall the names of those 2 physicians?
Sure. Dr. Husel and Dr. Hagris.
Is Dr. Hager still part of this group working nights?
Yes, sir.
Were you part of that hiring process?
I talked to the physicians, but it was not ultimately my final say one way or the other.
And this was in 2013?
Yes, sir. By best recollection, yes, sir.
All right. Can you tell the ladies and gentlemen of the jury what, if any, interactions you had with William Husel, one of the 2 that were hired, and or Dr. Hayes, just in general, and then any specific interactions you recall having when they began?
Your Honor, it's a compound question. If we could.
Rephrase.
Did you have, what, if any, interactions did you have with Dr. Husel when he was hired?
When he was hired or after he was hired? I apologize.
Well, at that time, in 2013, I mean, did you walk through, just tell them what you did.
When he was hired, I sat down with him. He told me his background. I told him what to expect with the job, basically. I'm sure I gave him a little tour of the ICU at that point. And that's kind of my interactions with him.
What about Dr. Haggis?
Objection is to relevance.
I'll permit it.
It was probably the exact same thing that I did with Dr. Husel.
And they were hired about the same time?
By my recollection, yes, sir.
All right. And were they hired for a specific shift?
Yes, they were hired to work from 7 p.m. to 7 a.m.
All right. Did they split the week then?
Yes, they would get together and make their own schedules and things like that.
All right. So what were your hours and what were your partner's hours?
We really don't have shift work. We basically would show up around 8:30 in the morning, and then we would basically stay until all the work was done. Sometimes that would mean we had to stay because of some of the governing bodies' regulations, but sometimes it'd be a 8-hour day, some days it'd be a 12-hour day. You can't predict sometimes with the ICU.
Okay. And is, just so for the jury's reference, is Dr. Giannuti one of your partners working day with you as well?
Yes, among others, yes.
Okay. So what, if any, interactions on a day-to-day basis between 2013 and 2018 did you have with either Dr. Husel or Dr. Haggis?
Objection, Your Honor, is to compound.
Two-part question is,
Yeah, well, that's a very hard objection.
what interactions between 2013 and 2018 did you have with Dr. Haggis?
If I was there late, taking care of a sick patient, I would say, hey, there's this sick patient, keep your eye on tonight. Or if there was a patient expected from an outside hospital, say, hey, there's a patient coming in. It was professional sort of checkouts as much as possible. The residents would do the formal checkouts, but if I was there late, which I was fairly often, I would be focused on specific patients in general.
What about Dr. Husel?
Very similar.
Did you have any interactions with Dr. Haggis outside of your professional relationship?
No, sir.
Did you have any interactions with Dr. Husel outside of your professional relationship?
No, sir.
Could you characterize how often you would have these interactions?
It would depend
Interactions.
with Dr. Husel or Dr. Haggis.
Let's start with Dr. Haggis.
It would depend if, obviously we're on a rotation, so in the weeks in the ICU, I would have those interactions. On the weeks I'm not in ICU, I would have 0 interactions.
What about Dr. Husel?
Very similar.
All right. Were there ever any formal or informal team meetings that would be arranged with the 2 nighttime ICU doctors?
Yes, Dr. Swanner would have set meetings with them, and if I could attend, I would attend the meetings, which I think was a good thing.
What was the nature of these meetings? What in general would we discuss?
Basically, just to see how things are going at night. You don't want the night people to feel isolated or that they're not appreciated. Having a night ICU doc is precious. You want to make sure that they're happy. Otherwise, I would be the one working nights in general. So you want to make sure that they're happy. They may bring up issues that you didn't think about that occurs at nights and things like that.
Were any of these issues ever brought up to you by Dr. Husel?
No, sir.
What was Dr. Husel's training to your understanding?
He was at the Cleveland Clinic and had done anesthesia as his critical care pathway.
Explain what that means, his pathway versus what?
Well, my pathway is internal medicine, so I did an internal medicine residency first, and then on top of that, I did the critical care component, a pulmonary critical care component on top of the internal medicine component. With there's several pathways you can become critical care certified, and that's the other way is through anesthesia because they also deal with the ventilators and things like that. So he did. I'm guessing I don't have his CV in front of me, but he did, or his resume. He went through an anesthesia program and then did additional year of training in critical care.
All right, so your pathway was internal medicine versus your understanding of Dr. Husel's pathway was anesthesia and then critical care.
Yes, sir.
And are there other pathways to become a critical care doctor?
I think there is also a surgical pathway. People who are surgeons can also do additional training and do surgical critical care. And even the neurosurgeons, I think, have a way to do neurocritical care, which is more specialized than just general critical care.
So there are several paths to do what you do.
Yes, sir.
All right. And you've done this since 1997. Do you know what Dr. Husel's prior experience in critical care was prior to him being hired in 2013?
No, sir. I thought he was just probably fresh out of his training, I thought, if I remember correctly.
All right. And are there any other doctors with Dr. Husel on a regular basis working his night shift with him?
Towards the end, I think we were incorporating some critical care nurse practitioners in general, but that would be about it.
Yes, but any other doctors, any other critical care doctors?
No, sir.
So that if there were questions on that shift, there were no other critical care doctors working with him?
That is correct, yes, sir.
And Hagris would be working the other part of the week?
Yeah, he would be rotating every other week. So one week it'd be Dr. Husel, the next week it'd be Dr. Hagris, unless they were on vacation or something.
If Dr. Hagris had any questions for you or for your team during the daytime, you having done this since 1997, could they have reached out to you at any point?
Yes, sir.
Could Dr. Husel, if he had any questions, being a new doctor to your understanding, reached out to you or to your team at any point with any questions or concerns? Could that have happened?
Yes, sir.
And to your memory, in the 5 years he was there, did that ever happen?
I don't recall that ever happened, no, sir.
So let's talk about palliative extubation. What does that term mean to you as a medical critical care doctor?
That means at that point you are removing life support and without plans of reinitiating that life support, and you still care about the patient, but your focus is more on comfort at that point.
All right. So that's what the palliative part means?
Yes, in general, yes. I use a different term, but
What term do you use?
I use compassionate extubation is the term that I use.
So instead of palliative, you use the term compassion.
I think it's easier for the families to use and interact with families. Palliative or terminal extubation is just harsh, I think, in general.
Sure. But the terminal extubation, terminal weaning, those are the same things.
A terminal extubation and terminal weaning is a little different. A terminal extubation is where you take the tube out of the mouth, while terminal weaning is where you just turn down the oxygen on the ventilator.
All right, so talk about specifically what's involved. So palliative means comfort care. Use the word compassion meaning comfort care. What's the extubation part mean? Explain to them what that physically involves, why that word is being used.
Could you repeat the question, I guess?
What does extubation mean?
Oh, I'm sorry. It means to physically take the breathing tube out of someone's trachea or windpipe, the big pipe in the lungs, and to take it out at that point.
Okay. And are there other times when you would extubate somebody besides in a palliative or compassionate setting?
Yes, sir. Hopefully when patients are better from pneumonia or when their lungs are damaged from smoking, and you can get them off the ventilator that way.
For people that you hope are going to live after you pull the tube out.
Yes, sir. Absolutely.
So let's talk about a regular extubation. Someone's going to get better, in your estimate and everyone's estimate, and it's decided medically to pull that tube out and get them off the ventilator, the machine breathing. What, if anything, is involved pain medication-wise in that process? In that process of we're going to continue on with their care.
You don't necessarily give pain medication at that point. You actually try to decrease the pain medications to a reasonable level so that they're awake enough to cooperate with you once the tube is out. That way the patient can cough and bring up secretions and help you with the extubation process.
Okay. What about benzodiazepines in a regular extubation, not compassionate, not palliative? what about any benzodiazepines? Do you give them any benzodiazepines when it's expected that their care will continue and life-saving care will continue?
Your Honor, I think it's irrelevant as to what's done with those that are going to continue life-saving measures.
I'll permit it.
No, you would try those are like Valium-like medicines that help relax you, so you would try to keep those at the lowest dose or discontinue those as well too.
So based on your training and experience, is the process of pulling that tube out, tell me where that tube is first. How's it get down there? Where is it? What's it doing down there?
It is placed through the mouth, between the vocal cords, and then put into the big pipe in the going to both lungs called the trachea, the big breathing tube right here.
Okay, so for the record, your point is like
To the middle of my chest, yes.
Yeah. And is that process, intubating someone, is that painful based on your training and experience?
It is uncomfortable. You do give medications to sedate the patient while you do that, because it's very normal I always make an analogy to families. It's like getting your throat swab for strep. You cough, you gag. It is uncomfortable. Put the tube in. Yes, sir.
All right. What about pulling that tube out? What's your experience and your training tell you about the level of pain and or anxiety that involves?
Most patients are glad to have the tube out because they're very awake and alert. You will gag a little bit, but the ongoing stimulus of the coughing and gagging has been removed, and so it's very slightly uncomfortable, but it's not painful in my experience.
Mr. Zion, can I see counsel sidebar?
Yes, sir.
Talk. So did you find out anything interesting about the jurors weekend?
We were talking about coaching.
It's one of her favorite hobbies. You ready there? Mr. Zion?
So let's talk about palate extubations. That's when, as you explained, you're not expected, restricted to comfort care at this point. No further medical life-saving measures are going to be used, right?
Yes, sir.
In your experience, what is that process? Not talking about in general, I'm talking about subjectively, your experience. What's the first thing you do?
It's a pretty lengthy process. Do you want me to go through?
Yes, I do.
Okay.
Well, first things first, Doc, have you ever done one?
Oh, yes, sir.
Okay. Now you can take off with it.
Thank you. How many do you think you've done?
Too many, I guess, with COVID, to be honest with you. Over my career, over 20 years, maybe 1,000 or so, and that I don't keep track. I don't know.
So you say it's a lengthy process. Start us at the beginning of this lengthy process.
Basically,
We'll get back here. I want you to speak up.
sure. Basically, you want to make sure you have a very good relationship with the family. You want to sit down and talk to them, and when they hit the ICU, you really want to find out who can legally make these sort of decisions. Who's the decision maker is what I always call. Who's the decision maker? You want to establish a relationship with that family. They want to be able to trust you, and you want to relay trust and confidence to them as well too. And then at that point, you've been updating them every day. I make family rounds every day. You update the family. You talk to them. At that point, ultimately, sometimes the body says they're not going to make it, essentially. And you sit down with the family and you try to figure out what that loved one would want under these circumstances. The first transition is you try to eventually but discuss with family code status is the first thing.
Explain code status to the folks here. No questions.
Sure. There's 3 codes in the state of Ohio, 3 code levels, for lack of a better term. One, obviously, is a full code. As I always tell families, if you keel over, I'm trained to come running in, try to restart your heart with the best technology available, best skills available. Not guaranteed, but we try our best. The second is a DNR-CC, which is DNR Comfort Care Arrest, which basically means we do everything up until the point where the heart stops. At that point, the heart stops. We don't go running in, shock the heart, beat on the chest, put tubes in the airways, things like that. Now, obviously, the third one is DNR Comfort Care, where at that point, again, the care doesn't stop. You still care about the patient, but your focus shifts on comfort as a top priority. So the first thing you want to do is, at least as a family, is DNR-CC arrest is usually the first step, because really this patient came in, usually it's a tragic event. The family's in shock, essentially. And so you want to give the family time to digest everything, talk about in-life issues as honestly and realistic as possible. And then after time, you sit down with the family and you say, the family will say, under circumstances, we don't want further aggressive interventions. And then they say, well, that sometimes means taking the tube out. And I try to go through that whole process of what that entails. And then I always like to have lots of ears in the room sometimes to listen. I like to get the bedside nurse in the room when I talk to the families and things. We have chaplain support that's always nice to have. And it is a process over time, but when the family reaches that, when I and the family the family is the patient advocate, I'm the patient advocate as well too. And at that point, if we decide somewhat together that it's time, then we start the process, we kind of pick a date and a time which is convenient for the family. We try to avoid holidays and birthdays and things like that. And then at that point, we would give medications to ease suffering and take the tube out with the family at bedside. I always like to be present, and then I like to always stop back by 10 minutes later, 15 minutes later, to at least say, hey, how's things going, and talk to the family as well, too.
So you said it's a planned event.
Typically it is, yes, sir.
In your 1,000 or so, would you ever characterize any of them as emergencies?
No, sir.
Let's talk about the medicines you give. You said on a regular extubation, you try to decrease the benzos and the pain medication. On a palliative extubation, or in your words, a compassionate extubation, you said you give medicines. Tell them why you're giving them medicines at this point, and at what point are you doing it? Are you doing it before the tube comes out, after, etc.?
Sure. Based on the disease state of the patient, sometimes I give medicine ahead of time. I use morphine in my practice. That's what I use, morphine. I use a drug called Versed or midazolam it's a Valium sort of medicine. It's a relaxation medicine. The nice thing about it also has amnesia properties as well too. So it takes away memory of this. And this is after I've prepped the family pretty hard. Here's what to expect. Here's what could happen. Things like that.
What specifically are you preparing for? What are symptoms, etc.? Tell us.
Sure. I basically talk to the family that the medicines that I give act on the top part of the brain. That's the part of the brain that perceives pain and suffering. But the human body is an amazing thing. It really is an amazing thing. The body will fight to live, even though the chemicals I'm giving affects the top part of the brain, so the patient's not perceiving pain, but the patient certainly may breathe fast, may have problems swallowing the spit from the back of the throat. Secretions is sort of the term for that. I always tell a family, you can be in the room when we take the breathing tube out. You can be outside the room and come right in. You can stay out in the waiting area, or you can be in the next county. I always say it's a personal threshold. We all have personal thresholds, and it's not a test of love to be in the room when this occurs.
Tell us about are there terms for that? Held your hand to your throat and said the rapid breathing. Is there a term for that?
Yeah, it's called agonal breathing, which may be either rapid, rapid, fast, shallow breathing, or it may be just intermittent gasp intermittently, not a normal breathing pattern.
With the medications you give them ahead of time or at whatever time you think is appropriate that affect the top part of their brain, the benzos and the morphine, that guppy, agonal breathing, is it also sometimes called guppy breathing? Am I using the right term there?
Sure, the rapid, shallow breathing, yes, sir.
Okay. Is that in and of itself inherently painful or anxiety-inducing for the patient?
For the patient, no.
And is that why you prepare the family for that possible symptom of the dying process?
Right. I tell the family that we are going to do the best to relieve any suffering as much as possible. But again, the human body's, once you take the breathing tube out, the dying process is the dying process.
What about secretions? Is there any medicine you can give part of this planning process to help with the secretions? Is that also sometimes referred to as the death rattle? Yes,
it's the noise in the back of the throat. Typically, we can give drying of secretions. Atropine is a commonly drug that's used. There's other medications. And you basically try to give that ahead of time a little bit as well, too. Sometimes it's very successful. Sometimes it's not as successful as I would want.
Now, when someone is intubated on the ventilator and before the DNR, CCA, or CC decision is made, do you ever give patients paralytics?
When a patient's on the ventilator? Yes, sir.
And what would be the purpose, what is the purpose of paralytics? And then first explain what are paralytics and what would be the purpose of giving them to them?
When you're paralyzed, I always make the analogy, it's like when you're going for surgery. You can't move. You don't want the surgeon cutting on something that's moving or anything, so you are actually not able to move. There's chemicals that prevent you from moving. When you're paralyzed with a ventilator, that basically means we are taking total control of your breathing at that point. That improves at times. The lungs' job is to do two things. One is to get in oxygen. The other is to get rid of the waste product, which is the carbon dioxide. And so therefore, the lungs, the paralytic, when we take over total control of the breathing, the goal is to improve oxygenation and ventilation with the ventilator.
What, if anything, as part of this described sometimes long process with preparation for palliative extubation, compassionate extubation. Do you do in regards to paralytics that a patient might be on?
It's extremely important to make sure that the paralytics have been cleared from the bloodstream.
Why is that extremely important?
Okay, hold on, doctor, that's in your practice? That's in your practice?
Yes, sir.
Okay.
I'm sorry.
And all of this, if I say anything,
Right.
ask you to opine about something that's not, I'm talking about your practice, your experience.
Sure, and I guess I should phrase, in my practice, I guess, you have to stop it ahead of time because you don't want to take the tube out and then the patient not making effort of breathing because that's not ethically the right thing to do.
Why not?
Objection, Your Honor, is what's ethically appropriate.
Yeah, I agree.
Okay,
Sustained.
ethics aside, in your experience, in your practice, what would happen to a person on paralytics if they're still on paralytics when you take them off the breathing machine?
Well, it deprives me of two things. One is the ability to assess how much pain and discomfort they are in because they can't respond to any stimuli. And it basically would not allow them to breathe even once you take the tube out.
I thought the purpose was so they could die. What difference does that make?
Okay, sustained.
And move to strike.
And strike, disregard the question.
How long does it take paralytics to wear off?
It depends on the disease process, how much liver disease, how much renal disease is present, the type of paralytics that's used. It varies, and you have to check for it before you take the breathing tube out, that it's cleared.
Okay, how do you check for it?
You do what's called a train of four. Fancy term, train, like a choo-choo train, but you put things to stimulate the muscles, and it puts a little electrical shock, not painful or anything. I do that to the residents to show them, but it basically makes you, if you give a little electrical shock, your hand will twitch, and you want to see all four twitches. If you give the shock and it doesn't twitch, that means that they're still paralyzed at that point.
And how do the paralytics clear the system?
Usually by either coming out in your urine, you're renally excreted, or cleared by the function of the liver.
So they just come out of bed, it's just a matter of time?
Yes, sir.
As part of this planned procedure, you have that time?
Yes, sir. And you prep the family ahead of time to tell them you would have to make sure the paralytic is cleared.
All right. Let's talk about the medicines you use as part of the palliative or compassionate extubation in your experience. What would you generally start with and the doses you would use?
Sure. Obviously, every patient is unique and different. Sometimes I would give the pain medications before the extubation, sometimes afterwards, but typically I use 2, maybe 4 milligrams of morphine and 2 of Versed.
All right. And do you use those at the same time?
Yes, sir.
And clinically in your practice, do you do that before extubation, during extubation, or after extubation?
Again, it's very patient specific. Some patients I feel comfortable with their disease process. I do not have to give it before extubation. If I do, I try to give it 10 minutes or so before to allow it to kick in or to be effective. And then afterwards, we would give it based on as-needed basis, called PRN, as-needed basis. And then we can give more smaller doses as necessary in that process.
Is there any danger in giving too big of a dose based on your training and experience and your practice?
Objection, Your Honor.
Okay, it's a great time to go to lunch. Ladies and gentlemen, the guy is here to supposedly fix the system. So let's come back at 1:15. Almost still only 15 minutes to make up for whoever was stuck in the traffic jam this morning. I heard it was horrible. Okay? I guess. I should stand. You guys have a great lunch. Okay, you can be seated. Doc, you're on the stand right now. You can't discuss your testimony with anybody. So if anybody comes to you and they
by someone for my expertise, and so I went and saw the patient, and then the consult note itself is a documentation of my thinking and documentation of my physical exam and documentation of what I'm planning to do or what I'm trained to do to intervene on behalf of the patient.
Right. Is that a fair and accurate copy and representation of that consult note on patient Ryan Hayes?
Yes, sir.
Your Honor, may I publish this, please? Showing the jury what's been identified as State's Exhibit 2D. So this is Ryan Hayes, right?
Yes, sir.
And this admit date was the day he came into the hospital?
Yes, sir.
For the record, I'm pointing to April 2nd, 2017. And then he was discharged on April 4th of 2017. Is that correct?
Yes, sir.
And if someone dies in the hospital, that's the same thing as quote-unquote discharged?
Yes, sir.
All right. And this is dictated by David R. Ralston. That's you?
Yes, sir.
And then you did this on the day he came into the hospital, correct?
Yes, sir.
And it looks like you spent 117 minutes, so that's a little under 2 hours on this.
Your Honor, deleting.
Just preliminary matters on this
How much
matter.
time did you spend with him, perhaps? Would you nominate questions?
Sustained, let's do the long one.
How much time did you spend with this patient?
117 minutes.
All right. And then the history of present illness. Can you explain to the jury what was going on with Mr. Hayes and what, if anything, you recommended?
He was a patient that came in through the emergency department, and he had suffered a cardiac arrest, if I remember correctly, or referring to the record, in his bathroom. I think he lived with his sister, and he had a history of prior IV drug abuse, so the suspicion was the sister found him, his heart was not beating, he was dead, and so the squad came with medications. They were able to restart his heart. Unfortunately, they don't know how long he was down for or his heart was not beating for, and they brought him into the emergency department. That's when I saw him.
Okay. Well, based on your training and experience, how long can a person's brain go without the heart?
It does vary. Young children, for example, and you hear about these freshwater drownings, they can go a little bit longer. But typically, the standard medical textbook answer, well, the standard answer, I guess, is 4 to 5 minutes in general.
Based on your understanding of the history of your patient here, had he exceeded that time?
Yes, sir.
What's a CT scan that's referred to in that exhibit?
A CT scan is a X-ray, basically a fancy X-ray, which gives us more detail than a regular X-ray, like you go to a doctor, get a chest X-ray. It is a computer tomography is what the CT stands for, and it allows the details to be seen a little bit better than a regular chest X-ray or X-ray of the skull, for example.
What, if anything, are you, and you did a CT scan of his brain?
Yes, sir.
What, if anything, are you looking for the results of that CT scan on his brain?
Well, just like if you hurt your ankle swells. Same thing occurs with the brain. When the brain is injured, the brain will start swelling as well too, and that's a sign of brain damage. If you see brain edema or swelling initially on the CAT scan.
So his brain damage can actually be visualized through this test?
The anatomical evidence of brain damage can be visualized. The function we don't know at this point.
All right. Well, anatomically, were you able to observe any brain damage on Mr. Ryan Hayes?
Yes, anatomically on the CAT scan, I did see evidence of brain damage.
Were you able to do any assessments as to whether functionally he had suffered any brain damage?
Yes, that's usually on the physical exam component.
And did you do that?
Yes, sir.
And what were the results of those tests?
If you could forward to the physical exam as a reminder, that'd be helpful to me. probably neurological right there. He did not have a cough. He did not have a gag. His pupils were fixed and dilated. He had no what's called corneal reflexes, where if people wear contacts, for example, you put something near the eye, they wince. They don't like things near the eye. This is my term for it. It's called bad doll's eyes.
What does that mean?
Back in the 1800s, when you're normally in a coma, you turn your head to the left or to the right. Your eyes will go midline back up towards the ceiling. That's normal. When you have bad doll's eyes, it's like back in the 1800s, the dolls used to have their eyes painted with wooden eyes. So you turn their head to the left or right, the eyes stay to the left or right. They do not come back up to midline.
What does that indicate?
Brain damage.
Why did you turn his respirator rate on the ventilator to a 4?
I was concerned initially about possible brain death. And so therefore, I was checking another reflex, which is breathing reflex. I turned his respirator rate down to 4. If he was brain dead, the ventilator is set, no matter what, to give you 4 breaths. He breathed over that ventilator rate, so that means he was not brain dead at that point.
Can you explain physiologically how all these other things that seem to be damaged don't seem to be functioning, and yet he's still overbreathing the vent, that he's not brain dead?
Sure. I'll explain how I explain it to families. I think that's probably the easiest way. The brain is really divided into 2 parts. The top part of the brain is our personality, our memories, our motor functions, things like that, while the bottom part of the brain is called the brain stem, or the primitive brain. And the top part of the brain is the first part of the brain to get damaged when you have low oxygen. While the brain stem, which controls our reflexes, stuff we don't even think about, coughing, gagging, blinking our eyes, and even breathing, is controlled by the brain stem. And that's the hardy part of the brain. It can take low oxygen a lot better than the top part of the brain. And that makes sense for the survival of the organism, for the human being. You want to be able to have the brain stem reflexes intact, especially breathing centers and things like that. So at that point, the top part of the brain appeared to be damaged. He's not interacting with me, things like that. The CAT scan shows cerebral edema or swelling. While the brain stem, although some of the reflexes were in bad shape, the one that would say, yes, the patient is progressing to brain death was still intact. So I can say the bottom part of his brain stem was still alive at that point.
Based on your understanding of Mr. Hayes' condition at this point, what, if anything, did you tell the family, and or can you tell the jury about his ability to perceive pain?
Well, the top part of the brain is also the part of the brain that does perceive pain as well. I always make the analogy to the family, if you have a hot spoon and a baked beans, for example. I like baked beans. And if you come home and grab that spoon and it's hot, your reflex, the reflex is to let go of the spoon. And then moments later, that's when you feel the pain in the top. You perceive pain in the top part of the brain. So there's the reflex is one thing, but the perception of pain is located in the top portions of the brain.
And that, based on your examination of Ryan Hayes, is he able to perceive pain at this point?
Objection, Your Honor. Opinion.
It's based on your examination.
He's not a neurologist.
Okay, sustained. Let's rephrase.
What, if anything, did you tell the family about his ability to perceive pain?
I told the family at this point he did not seem to be in pain or suffering at this point because of the brain damage from the low oxygen.
What, if anything, did you tell the family regarding his ability to perceive anxiety?
I basically, again, that's an emotion or a stress of some sort, and the top part of the brain is in charge of that also. He's not in pain or hurting or anxious at all.
Is there any chance, did you tell the family there was any chance that those parts would heal themselves, come back at some point during his stay?
No, sir. I typically tell families We don't know if his brain is going to recover. Usually in these cases, it does not.
And based upon your examination and your report there, did you recommend that Mr. Hayes receive any pain medication or any anxiety medicine when you examined him in the emergency department?
There probably at the time was some PRN medications, but no, at that point, he did not require them at that point.
Did the family want to wait?
Could you go back to my assessment and plan and on the second last, I'm sorry, go back down a little bit more. Yeah, on the bottom of that page is, I guess I could take my pointer, that'd be better.
Yeah, there's a pointer there for you. If you can point to the jury what you're talking about, please, if that helps.
So, oh gosh, I'm sorry. I'm shooting through glass here. I apologize. The family is somewhat assistant, and then next page. Down a little bit so I can read it. I'm sorry.
Either way.
Either way.
Oh, sorry.
Okay. And according to the families, his wishes were to stop. The family said, hey, we know him, we want to stop that point. I'd already, even before I saw him, they had already made him with the ER doctor a DNR CCA, which is, again, if the heart stops again, we weren't going to restart it. But by the same token, then they were also very interested in organ donation. Out of this tragedy, they wanted something good to come out of it. So I sat and laid down the three options at this point. The first option, of course, here I'll go. Option one is if they want, absolutely, we could stop at that point. He would die, but they would not be able to harvest the organs for transplant. The second option, I guess, I was afraid that over time, he might go ahead and proceed into brain death at that point, and at that point we declare him brain dead, and then organ transplantation can occur after a patient has been declared brain dead. And let's see, and then the third option is kind of a unique, let me go back. First option, extubate now, he would die without organ donation. The second option would be do this thing called circulatory death. In other words, donation after circulatory death, after the heart stops, then talk about harvesting the organs then. And that's very challenging to do, but it can be done. And then the third thing is just wait a little bit and see if he proceeds into brain death at that point. And then at that brain death, then he'd be able to have his organs donated to other people that way.
And brain death would mean that lower part of his brain just stop working on its own?
Yeah, not only the top part of the brain would have died, but the brainstem area would have died as well too. The primitive part of the brain would be dead.
And what did they think was the best option?
Let me read through here a little bit. They thought the best option...
hold on.
Objection as to what they think, form of the question.
Okay.
What's indicated on the medical records, perhaps.
Let's rephrase.
What's indicated in the medical records they thought the best option would be?
Let's see. I think at that point they decided to wait, and I did try to encourage them. There was a estranged son in North Carolina. And these tragedies, you like to have families get together and be together as well too.
Did you then discuss with them how much pain he would be in if they decided to wait for brain death and or the estranged son to come back?
Yes, sir. I said he's not going to have more pain or anything like that by waiting.
Or anxiety?
Objection leading.
Sustained. Ladies and gentlemen, disregard the last question.
Did you discuss whether he would, anything regarding the anxiety he would be feeling?
Yes, he would not be having anxiety.
Showing you what I'd marked for identification purposes. This states Exhibit 8C. Can you show us what 8C, can you tell us what 8C is if you recognize it?
Sure, it's a consult dictated by me on May 24th, 2018.
And what patient does that involve?
James Allen.
Is that fair and accurate?
Yes, sir.
Thank you. And was that another, where did you see him?
I think originally I saw him, if we could post it, but I think I saw him, I actually went down to the emergency department to see him because he was so sick.
Okay. So you saw him when he first got to the hospital?
After he was seen by the ED physicians, yes, and ED staff.
All right. And so this was can you tell us about how this man presented?
Sure. He was an older gentleman with medical problems in general, COPD. I think he had dementia as well too. And actually, I saw him back in 3 years earlier when he had a weak heart, and so weak hearts have a tendency to go into bad heart rhythms when he was in for a ventricular tachycardia. He had what's called a cardiomyopathy. His heart was not pumping very well. Normal values around 60%, and his heart was pumping around 10 to 15% at that point. He came in with some vague abdominal discomfort and some jaundice or yellowing of the skin as well too.
All right. And he was admitted to the hospital at that point?
Yes, sir.
All right. And finally, showing you what I marked for identification purposes, has State's Exhibit 11C. Okay. Do you recognize State's Exhibit 11C?
Yes, sir.
And what is 11C, please?
This is James Timmons, a consult on James Timmons.
All right. And when did you see James Timmons?
On 10/22/2018.
Is that fair and accurate?
I'm sorry, don't mean sorry about that. Yes, sir.
And what was Mr. Timmons' discharge date? If he had passed, what would have been that date?
10/24/2018.
All right. And it looks like you saw him on 10/22. So you saw him when he came in again?
Yes, sir.
All right. So if the records would show further that these patients were later palliatively extubated, the 4 we just went over, I believe it was 4. These would have been the same patients that would have been, if admitted to the ICU, would have been seen by the nighttime ICU doctors.
Yes, sir, if they were having issues or problems at night.
At some point in 2018, were you called by Dr. Swanner regarding the dosing habits of Dr. Husel during palliative extubations in the nighttime ICU?
Yes, sir.
Tell us about the circumstances of that and what you remember.
Sure, I was on vacation at Disney World, and when I came back on Sunday, there was a message on my flip phone. I had a flip phone back then about, hey, call me or whatever. And then I called Dr. Swanner, and he said we'd like to have a meeting with Dr. Husel and himself.
Is this the first time any concerns about Dr. Husel's dosing habits during palliative extubations in the nighttime ICU have been brought to your attention?
Yes, sir.
What happened next?
The next day, we had the meeting,
Where did this meeting take place?
Dr. Swanner's office,
And who was present at this meeting?
myself, Dr. Husel, and Dr. Swanner.
All right. And without telling us about what other people said at this meeting, what, if anything, did you say at this meeting?
I was,
Objection vague.
Let's not lead it, but let's bring it
All right.
in a little bit tighter.
What, if anything, did you say about your dosing habits at this meeting during palliative extubations in the daytime in the ICU?
I discussed my habits, what I typically do, the dose of medications that I use. I did emphasize you have to document everything extremely carefully in these cases, and that was my role, so that's what I did.
Okay. And did you describe your dosing habits in that meeting the same way you have described your dosing habits here today?
Yes, sir.
Were you made aware that Dr. Husel dosing habits include administering 1,000 micrograms of fentanyl in an IVP push during this meeting?
Yes, sir.
Were you made aware that Dr. Husel's habits included dosing 2,000 micrograms of fentanyl via IVP intravenous push, meaning all at once?
I was not aware of that.
Okay, but you were aware of the 1,000?
Yes, sir.
And on the equal analgesic chart, and did you have any familiarity with fentanyl during palliative extubations?
No, sir.
All right, you used morphine.
Yes, sir. I don't like to use fentanyl because the street drug related to it. It's people associate with street drugs.
Okay. And using that equal analgesic chart, what would be the equivalent dose of morphine all at once? If you were to, what's the equal analgesic dose of morphine to 1,000 micrograms of fentanyl?
It would be a 10-to-1 conversion, so it'd be 100 milligrams of morphine.
All at once.
Yes, sir.
Have you ever, in the 1,000 plus palliative extubations you've done, given 100 milligrams of morphine during a palliative extubation?
No, sir.
Have you ever used 100 milligrams of morphine for anything in the ICU in your 27 years, all at once?
No, sir.
Have you ever used 90 milligrams of morphine during a palliative extubation in your 27 years in the ICU, all at once?
No.
Have you ever used 90 milligrams of morphine for anything in the ICU all at once in your 27 years?
No.
What about 80 milligrams of morphine,
Your Honor, I
sir?
think we've covered this.
Why don't you ask him what the most he's ever given in his experience? Okay, well, let's keep doing that.
Same question, 70.
Objection, Your Honor. He's actually already answered what's the most he's ever given some time ago in his testimony.
And now he gets what he usually does.
These are different questions.
Okay, I'll let you have the 70, but let's get to it.
Well, let's get down to it. Anywhere between 20 and 60. All at
No.
once.
No.
And I'm not talking about just during comfort care, someone's critically ill, dying, helping them pass. I'm talking about anything.
No.
What's the most you've ever given in morphine during a palliative extubation? You said you've done over 1,000.
Spread out over time or
All
at
at
once?
Biggest IVP push.
Maybe 5 or 6, something like that.
And that would be equivalent to
60 micrograms of fentanyl.
Thank you. I have no further questions.
Ms. Menashe?
Diane Menashe, on behalf of Dr. William Husel. I'm going to have a lot of territory to cover with you today. So let me start with, you've been, in this case, interviewed, you had an HR interview at Mount Carmel?
I don't think so, no.
Okay, you never had an HR interview?
I'm not sure what you mean by HR.
Human resources?
No.
Okay, so you had a interview with the Columbus Police Department?
Yes, ma'am.
And you had a meeting with Dr. Swanner and Dr. Husel, is that correct? That you just testified to?
Yes.
I want to lay out the timeline so that the jurors understand the timeline that we're talking about here for these events. The meeting with Dr. Swanner and Mr. William Husel was on November 26th of 2018, correct?
Yes.
You were, for the first and only time, interviewed by the Columbus Police Department on November 14th of 2020. Is that correct?
Yes.
And I want to make sure I'm right that between November of 2018, the meeting, and your first interview with Columbus Police Department 2 years later, that in that time of 2 years, you never met with anyone from the prosecutor's office.
That's correct.
And the reason why I ask this is because today, during your direct examination, you were asked so many questions, were you not, Dr. Ralston, about your opinions as to what you do in your practice and what's appropriate with respect to palliative extubation.
Rephrase it. Sustained rephrase.
You've been asked on direct all these questions about what you do in your practice. Would you agree with me on that?
Yes.
Lots of questions about what dosages you give during palliative extubations, right?
Yes.
And lots of questions about who's in pain and who's not in pain, right?
Yes.
And then these last line of questions, the 100, the 90, the 80, the 70s, the court allowed, you were asked those questions.
Sustained, counsel.
You were asked questions.
Strike the question, start over.
You were asked the last questions about what's the most you've ever given, correct?
Yes.
But you were not, are you aware of the date of when my client was indicted?
No, ma'am.
Would it surprise you to know that he was...
Objection, Your Honor.
Sustained.
For those 2 years of time between when you met with Mr. Husel and when the police department interviewed you, no one else spoke to you about the questions that were asked of you today. Is that true?
Objection, asked and answered.
I'll permit it.
I think someone from Trinity did come and interview me in that time frame. Yes, ma'am.
And other than someone from Trinity, no one else from the prosecutor's office or police?
No, ma'am.
Did you, I'm going to ask you about that interview that you had with Columbus Police Department in October of 2020. The detective that was there with you that day was Ann Pennington, is that correct?
I have no reason not to believe that, yes.
Do you remember you were asked during that interview about how you personally felt about learning of Mr. Husel's, Dr. Husel's dosing habits, if you will, with respect to fentanyl? Do you remember being asked about that?
Yes, ma'am.
And in particular, you were asked, were you not, if it quote-unquote shocked you? Do you remember that question?
Objection, Your Honor.
I'll permit it.
I don't necessarily remember that. I don't know. I don't remember what I was asked, not asked, so I apologize.
No, please don't apologize. Let me ask you this question. Isn't it true that during your interview with Columbus Police Department, which was approximately 2 years after the interview with Dr. Husel, that you actually said that the dosing habits don't surprise
Objection,
you?
Your Honor.
It's cross-examination, right?
Yeah, I understand it's cross. I was waiting for you to finish your question.
Okay. That you actually said that it didn't surprise you because, to be fair to your partners and to your patients and families and Dr. Husel, that you needed to be at bedside to really understand if those dosages were appropriate or not. Do you remember saying that?
Yes, ma'am.
And isn't it also true, Dr. Ralston, that you've been completely consistent about that point because you made the same point in your deposition testimony in a related civil case, did you not?
Yes, ma'am.
You said, did you not, you can't speak for the practice of another physician because you weren't at bedside.
I think that a physician at bedside is very important, so yes, ma'am.
And in each of the patients that you were just asked about, and we will go through them, but you would agree with me that when they were palliative extubated, you were not bedside.
That is correct.
And you would agree that when they passed, you were not bedside.
That is correct.
I want to go through, let's just start with some basics. In your capacity as the medical director of the ICU at Mount Carmel, fair to say you would know how many critical care physicians worked within that facility between the years 13 and 18?
Yes.
And would you agree with me that it was 6?
It was probably more than 6.
Okay, tell me how many it was.
I think we had 6 daytime people and 2 nighttime people, so maybe 8 in general.
Okay, you know the nighttime would be Dr. Hagris and Dr. Husel?
Yes.
And then in addition to those 2 critical care physicians, there would have been 6 more.
6 critical care, but not in the ICU at the same time.
Okay, so in all of Mount Carmel West, between 2013 and 2018, there was 8 total critical care physicians.
Yes.
So, and just a general question, obviously 2,300 is not an accurate number as to how many critical care physicians were within that entire hospital during that 5-year time. Do you agree with me?
Yes, I'm not sure where the 2,300 came from. I apologize, but no.
Yes. Let's go through your direct if we can. You just generally said that people in ICU, and I wrote this down, but of course, tell me if I'm wrong, they're generally very sick patients. Would you agree with me on that?
Yes, ma'am.
And I know when you talked about your career path and how you came to Mount Carmel, but with respect to Dr. Husel, you understand or you know from your own personal knowledge that he did his 4-year residency in anesthesiology at Cleveland Clinic.
Yes, ma'am.
And then he did his additional year with respect to critical care medicine also at Cleveland Clinic.
Yes.
And then he was hired by Mount Carmel Hospital. Is that correct?
Yes.
In 2013?
That seems about right, yeah.
And you talked about sort of the pathway, how you get to be a critical care physician. Do you remember that line of questions?
Yes, ma'am.
Your pathway, fair to say, was internal medicine.
Yes.
Dr. Husel's pathway is anesthesiology.
Yes.
Dr. Hager's pathway is internal medicine.
Yes.
And you would agree with me that there's not one other critical care physician at Mount Carmel West during this period of time whose pathway was the same as Dr. Husel.
That would be correct.
He's the only one that's anesthesiology to critical care.
Yes.
I know we've now dated the meeting that you had with Dr. Swanner and my client, Dr. William Husel, as being in November of 2018. That sounds correct?
Yes, ma'am. It was the Monday after Thanksgiving holidays.
And you remember that, I assume, because of your vacation?
You remember vacations when you're a critical care doctor. Yes, ma'am.
You would agree with me that before you got that call from Dr. Swanner, that at no period of time in 2013 had you
That is correct.
And the same question about that year, no complaints in 2013 from any physicians about Dr. William Husel,
That is correct.
or anyone in critical care, correct?
That's correct.
And even, again, different, I'll put from physicians, is you had that daily contact with residents, did you not, during this time frame?
Not daily, just when I was in the ICU.
Okay, and that's right, you kind of worked,
You rotate through.
rotated through. Tell me, doctor, if you recall, isn't it true that when Dr. William Husel was done with his shift, that you, as the medical director of the ICU, would know, that he actually then had to get together with the residents that were coming on shift and have a meeting?
Yes.
And he would do that as protocol, would he not? He would leave at 7 a.m. and confer with the residents that were coming on shift.
Yes.
And that conference, if you will, was it not, the purpose of it was to tell the residents about any events or issues that happened and or needed to be carried over.
Yes. Pass along information. Yes.
And you have no information that those meetings never took place, correct?
I'm sorry. Can you ask the question again?
Sure. You have no reason to believe that that didn't take place as a matter of practice with Dr. Husel, correct?
I have no reason to believe otherwise. No.
So let me then go back to 2013. In addition to nothing from nurses or physicians or anyone in critical care, you also didn't hear anything from any resident in terms of complaints about Dr. Husel.
No, ma'am.
And then same group of individuals, nurses, physicians, critical care, residents, no complaints in 2014.
No, ma'am.
No complaints in 2015.
No, ma'am.
No complaints in 2016.
No, ma'am.
No complaints in 2017.
No, ma'am.
No complaints in 2018.
Except until the November thing, phone call. Yes.
Right, you get the call from Dr. Swanner in November.
Yes, ma'am.
You were asked about whether or not Dr. Husel ever reached out to you with any questions. Certainly you made yourself available, right?
Oh, yes, ma'am.
And I remember during your interview with the Columbus Police Department, when you talked about if there were issues with your dosing, that you would expect a pharmacist to give you a call if there are any issues. Do you remember talking about that?
Yeah, if there was anytime I make a mistake, or, I mean, I'm human, I make mistakes or whatever, if something seems funny, or I expect the pharmacist to reach out and let me know, or the nursing staff to let me know.
And that was my next question. And you said that you expect the same of the nursing staff, right? If they see issues or problems with something you've done or ordered, that they would communicate that with you.
Right, the pharmacist's role is to be patient advocates, and the nurse's role is to be patient advocates as well. Yes, ma'am.
And fair to say, doctor, that at your time at Mount Carmel, you rely on the fact that pharmacists and nurses are patient advocates.
Yes, ma'am.
I've got some questions about the pain discussion, about whether being intubated or extubated is painful. I noted that you said that being extubated wasn't painful.
It's a matter of perception, the difference between pain and comfort, I guess, or uncomfortable. It's not the most painful thing in the world, but it is uncomfortable, I guess, would be my answer.
Have you, and so I'm just getting a question. If I were to say, and I am going to ask you, that I have gone through an extubation and I found it painful, would I be lying?
I don't know you that well, but I'd probably say no.
You talked about palliative extubations and when making the decision to palliatively extubate. And I want to go through kind of the things you talked about on direct. One thing is you established the relationship with the family, right? You talked about that.
Yes, ma'am, I think that's very important.
And so that would include, let's just say, if the extubation, the decision to extubate was made during the nighttime shift, that would, in your opinion, require Dr. Husel to speak with the families.
Yes,
correct?
ma'am. Yes, ma'am.
And typically, I know you said your preference is to have peers there, nurses there,
Yes.
and even spiritual care staff and chaplains worked at the night, did they not?
Yes.
And they were often, during any kind of decision like this, would come and be with the family and spend as much time as needed. Is that fair to say?
Yeah, it's a very challenging and tragic time for everyone.
And which reminds me, I remember during one of your questioning, or I'm not sure if it was your depo or your police department interview, but you were asked about being an ICU doctor, and you said it's a very demanding job. Do you remember saying that?
Yes, I'd say it today. Yes, ma'am.
Because it can be quite stressful.
Yes, ma'am.
And fair to say that those around you, right, particularly the family members, it's a very stressful situation for them as well.
Yes, they have no experience, and my job is to try to help them through the difficult discussions. Yes, ma'am.
And you indicated on your direct, I wrote down that when you were asked about the code statuses and the 3 statuses, when the decision is made by the family that it should be a DNRCC, that comfort is then your top priority.
Yes, ma'am.
Could you explain to the jurors the doctrine of double effect? As you understand it.
I'm not an I'm not an ethicist or whatever, but it's to, when you do something to someone, a patient, whatever, the goal is good, even though it may cause short-term problems. For example, if I stick a special IV in someone's neck, like a central line, that causes discomfort, but the goal is to have access for medications and support. Or same for intubation. It's uncomfortable intubating, so you know it's uncomfortable, but you're trying to save their life.
And so the good outweighs, if you will, the potential harm or bad that could happen.
I'm sure that's a definition. I've never really heard double effect that much. So
You haven't heard it that much?
no.
Let's talk about those questions about whether a palliative extubation is ever an emergency. Do you remember that line of questioning?
Yes.
I mean, by definition, the process of a palliative extubation, once the decision is made by the family, takes some time, does it not?
Yes, ma'am.
Okay, so the physician places the orders, or I'm sorry, gives the verbal orders, right?
Usually you place them on the computer.
Okay, and then the nurse will facilitate the orders?
Whatever nurses do, yes. I don't know.
Okay, and I'm going to get back to you about whatever nurses do, but then there's a period of time between when the medicine is placed, right, and the medicine is obtained, and then the medicine is administered.
Yes, ma'am.
Right? So these questions about emergency, a palliative extubation, by definition, wouldn't you agree, takes some period of time between when the decision is made and to when it is carried out?
Yes, ma'am. It can be hours, or it can be even a day or so. Yes.
And I remember you talking about that it could be within an hour, or it could be within 22 hours as to when it's carried out, right? From when the family makes the decision.
Right. Sometimes you have family members traveling or trying to get there, things like that. So that weighs into those discussion points as well. Yes.
And you would agree with me that, as the medical director of the ICU, that one of the things that was a capability of Dr. Husel in his capacity during 2013 to 2018 was to oversee palliative extubation.
Yes, that would be his role as a critical care physician. Yes, ma'am.
And so I just have a question for you. If you're working in the ICU and let's just say someone makes a decision to change the code status of their loved one to DNR CC, and a palliative extubation is impending,
Sustained.
Tell me this in your capacity. Dr. Husel was hired to be part of the critical care staff and doing palliative extubation as part of his job.
Yes, by the hospital, yes.
Right. There was no rule at Mount Carmel West that palliative extubations could not be done during the nighttime shift, correct?
That is correct.
And in fact, I guess with respect to rules, there was no maximum dosage with respect to fentanyl at Mount Carmel West between 2013 and 2018, correct?
Not that I was aware of.
And you have testified to this jury that you used morphine during your palliative extubations.
Yes.
And fair to say, in your personal knowledge as the medical director, that actually everyone else that was in critical care used morphine except for Dr. Husel.
I can't speak for the other practices. I didn't know it at the time. Just for my practices, I did.
Did you know of anyone else that was using fentanyl?
Objection, asked and answered.
No, he hasn't answered that one. Do you understand the question?
Could you just repeat it? I'm sorry.
Remembering back to that time frame, do you remember anyone else in critical care that was using fentanyl?
Not that I was aware of, but again, I didn't really talk to anybody else about their practices in general.
I want to talk a little bit, while I'm on the subject, about morphine versus fentanyl. You use morphine. Fair to say that morphine has a double peak.
Yes.
So it peaks, and then it peaks again.
Yes.
And if you know, fentanyl has just a single peak. Is that true?
Yes.
And I wanted to be clear, because I got a little soft-spoken, but you testified on direct that you didn't use fentanyl as a practice because it had a negative connotation because of its street use. Is that fair to say?
Yes. It was responsible for a lot of overdoses, especially in the Franklinton area in general. Yes.
But you obviously agree that there's a difference between kind of the street drug fentanyl and the medically used fentanyl within the hospital system.
Yes, my perception, but it's the family's perception that I was focusing on.
And that's why you were talking about the negative connotation.
Yes, ma'am.
And so going back to this emergency line of questioning, I know during your this relevant time frame, 2013 and 2018, sometimes you would work late.
Yes, ma'am.
And
A lot of times I'd work late. Yes, ma'am.
because it's just nature.
It's a job.
And would you work so late that you would go into the night shift?
I was completing the work, but yeah, I'd work 8, 9 o'clock at night. Yes, ma'am.
And sometimes, fair to say that you would actually work the night shift, picking up shifts or otherwise.
Yes, ma'am, occasionally.
And forgive me for these questions that I'm about to ask that might sound stupid, but here I go. At the nighttime in the ICU at Mount Carmel, I'm assuming there's lights.
Yes, ma'am.
Lights are on.
Yes, ma'am.
Because there's lots of questions about the cover of darkness, and I just want to make sure that the lights are on during the nighttime in the ICU.
Yes.
And there are nurses there.
Yes.
And there are charge nurses there.
Yes.
And there are chaplains there.
Yes.
Other spiritual care staff.
Just the chaplains, I think.
Okay. And the monitors are on. Is that fair to say at the desks?
And in the rooms, yes, ma'am.
And in the rooms, right? Things are on. Things are alive in the ICU, right? Even during the night shift.
It's a 24-hour place, yes, ma'am.
Okay. And also in the ICU, wasn't it on the 4th floor at this time?
Yes.
Of the building. Right? So it's not like it's in the basement under the cover of darkness. It was on the 4th floor?
Yes, ma'am.
You mentioned a number of times about how it's patient-specific.
Yes.
And when I say it, fair to say your dosing practices are patient-specific. Is that right?
Yes, ma'am, within parameters, yes.
And
It'd be hard to limit to 4, but I would say first is the disease process. What are they in pain in general? The second would be, again, brain. The brain is the key component, especially a lot of these are after cardiac arrests. The third would be age of the patient. Fourth would probably be liver and kidney function. And last but not least would be family input as well too.
And what about things like tolerance?
You can't really measure, judge that, so tolerance doesn't really influence my input that much in my practice.
Do you agree with me, doctor, that 2 doctors with similar education and background and experience could have differing opinions as to how best to treat a medical situation?
Yes.
I think when you were asked about going back to palliative extubations, do you remember when you indicated that you were asked about whether you ever gave benzos, and you indicated that it takes 10 minutes for them to kick in. Did I write that down correctly?
Yes, well, in general, we try to give approximately 10 minutes before in general.
And so if I get benzodiazepine through an IV, it would take 10 minutes for that to have its desired peak effect on my body.
It can. It again varies from person to person. So it'd be a judgment call at the time of the extubation, whether you have to give more.
And just so we're talking numbers here, I get it in my IV and I die 75 seconds later, right? We've then got, 8.5 minutes until that medicine peaks?
Okay, stop. Let's go sidebar. Ladies and gentlemen, let's talk amongst yourselves. Come on. David's here with news stories of the weekend. talk to David, what your positions are. I will not be able to take everything down. The battle is raging right now, okay? The question becomes is, what's the convenience? I would like to take down the glass in front of the witness to enable you guys to hear better, okay? The rest of it's up to you guys, because the audience, I'm not as concerned as you guys. So you guys have a talk, each of you, with David over the next day. Okay, express yourselves. If you got no opinion, say you got no opinion. Okay? David will not tell me who wants what. Okay? He's going to give me a summary of what's going on and any concerns. Okay? Because this is about, I want you guys to be comfortable, I want you guys to be able to hear. Okay? So that's the big issue with me. My own personal thing, I can persevere. But for you guys, that's what I'm concerned about. So you guys express to David what your opinions are. Okay? Ms. Menashe, I'm sorry about that, but I wanted to get that public service message on.
Transitional question, so I'm going to leave it, not to mention it's cross, but in your experience in critical care medicine, I get the benzo through an IV, 10 minutes until it gets its full effect on me.
Objection, Your Honor. This is once again hypothetical, referring to herself hypothetically if she were to be given this.
I think she's, okay, stop. It's my job here, okay? Both of you two. She's okay with her question so far.
I'm sorry, could you repeat the question?
It takes 10 minutes to take its full effect, correct?
What, to take its full effect? I'm sorry.
The benzos that you were asked about on direct examination, you get.
It can vary from person to person and disease state.
Sure. But on your direct examination, you said a general 10 minutes, correct?
That for a generic ballpark person, sure.
I want to talk about vasopressors along those same lines. Palliative extubation, fair to say that you, before the extubation is done, the vasopressors are stopped.
Usually almost, you try to do it simultaneously at that point.
Okay. Would you agree with me? Tell us what vasopressors do, vasopressors do.
Sure. Vasopressors are medicines, usually epinephrine type of drugs. Most people are familiar with epinephrine, which help raise the blood pressure when blood pressure is critically low and the heart's not pumping very well.
And fair to say it's something that can help keep someone alive.
Yes, it's designed to keep them alive.
And so when it's stopped, if you know, in your experience in critical care, isn't it true that it takes about 1 to 2 minutes for the vasopressors to leave my system?
Yes, the onset is very quickly and the off is very quickly, although I've been surprised at times when I stop the vasopressors, the blood pressure rises, and I have no reason to explain that physiologically sometimes.
And doctor, because isn't that kind of the phenomenon with medicine? Like anything can happen, right?
That's probably life also. Yes, ma'am, anything can happen.
Are you familiar, in your experience and capacity as the director of ICU, of what is called a discharge summary?
Yes, ma'am, I don't do them, but yes.
And if you know, does an attending physician do the discharge summaries?
Yes, whoever the patient is admitted to, it's their responsibility to do the discharge summary. Usually in the internal medicine side of things, it's the hospitalist, the person in charge of the patient in the hospital.
And Dr. Ralston, in your experience, in your capacity, just a guesstimate, how many times do you think you dictated a medical record?
I'm sorry, a medical record is the whole thing.
Electronic medical record. Like how many times have you dictated an event that happened at a hospital?
Like a progress note or a consult or
So any entry you would put in, how many times do you put an entry in?
thousands. I would have no idea. Millions, I'm not sure.
Right? But isn't it true that every single time you enter an electronic medical record, whether it's a progress
yes, I'd hope they would read it because I'm the consultant and giving advice.
I want to go through the patients if we could. I'll start from the reverse. I'll start where you ended. Showing the witness what's previously been marked as joint exhibit 11, page 18 to 20. Just want to make sure the jurors can see this, though. Thank you.
Kind of fuzzy on the outsides,
Okay.
but you're good.
Okay. Fair to say this looks like it relates to patient James Timmons, correct?
Yes, ma'am.
And with respect to all of the patients that you were asked about today, I believe there's 4, you have no independent recollection as to these patients. Is that fair to say?
That'd be correct.
And in fact, this is the purpose of dictating things like consultation notes or progress notes so that you can go back and refer to them.
One of the functions, I guess, legal function, malpractice, things like that, yes.
So we're relying on the medical records because you have no independent recollection. And I want to show you your notes on patient James Timmons, if we could. Fair to say that the critical care time was 118 minutes, as noted.
Yes.
Okay. And this individual comes in, I think this is an overdose situation. Would you agree with me on that?
That was the presumption at that point, yes.
And right down here, it indicates while he is on the phone, he had, and what is that word? Describe that word for the jury, if you will.
He basically, his heart stopped.
According to the emergency department physician, correct?
I had gone down and saw the patient, and then I was coming upstairs to try to say, hey, let's get this guy up here quick. And the ER doc called me and said, hey, his heart stopped again.
And his heart stopped again.
Or, let me see here a second. No, his heart, that was probably the first time it stopped then.
So, and fair to say, so he had cardiac arrest,
Yes.
right?
Yes, ma'am.
I'm going to go to second page where these notes are. And I'm sorry, just to be clear, this is your name here on this consultation?
Yes, ma'am.
Okay. Go here to the vital signs. Would you agree with me? It says noted and currently not stable.
Yes.
Okay. And then it indicates the blood pressure there.
Right. His blood pressure, the blood pressure is really 2 numbers. One is the systolic, one's the diastolic. In this case, the systolic blood pressure was low in the 80s when normal values are like 120.
You anticipate my next question. And then going to the third page of your consult, if you will, it's indicated that this patient was presenting after being found down for 48 hours.
Yes, ma'am.
And you would agree that that probably accounts, in your experience, for the fact that his glucose was at 29 because he had been down for 2 days.
Right. Down is a tricky term. It's used interchangeably sometimes. Sometimes in medicine, you think someone down, their heart stopped as being down. In this case, he was just laying there, not moving. His heart was still beating at that point.
Right. But we don't have an eyewitness as to what happened to him during that 48-hour period of time, right?
That's correct, yes.
Okay. I want to go now to your last note here. Would you agree with me that you wrote overall prognosis is quite guarded at this point, and he is at high risk of undergoing another cardiac arrest?
Yes, ma'am. He had high potassium in his bloodstream, and we were setting him up for emergent dialysis, which was to remove the potassium from his bloodstream. So, yeah.
And witness what's previously been marked as Joint 11, Joint Exhibit 11, pages 31 through 38. Again, Dr. Ralston, does it appear that this belongs to the same patient?
Yes.
And if you could just see here the progress notes, does it appear that your name is on that document?
Yes.
Okay. I want to just go up here to this section right here. I'm going to zoom out a little bit. If you could, right here where it says positive, fair to say that's for cocaine?
Yes.
And is this second positive for, is that THC, what we more commonly know as THC?
Yes, marijuana.
Marijuana?
Yeah.
And so I ask you this because if an expert or someone that reviewed this document indicated that the toxicology report was negative, that would not be correct. Is that true?
Yes, the toxicology report, urine toxicology reports does miss fentanyl or synthetic morphine type of drugs.
And then going to the second page of this document, again, the critical care 121 minutes, that coincides with the previous exhibit we saw. Is that fair to say?
I believe this is perhaps from the next day when I saw the patient
Yep, let me make sure.
on 10/23, I'm guessing. This is a guess, though.
Yes, you are right. So this is from 10/22. And so this exhibit we're now looking at is the next day.
Yes.
Okay. And fair to say then the next day, so the day before Mr. Timmons passes, the note in your progress notes, is it not, without the ventilator, pressors, and interventional critical care, patient would die or have organ damage?
Yes, ma'am. Without life support, life is no longer supported.
And then these are your subjective notes here. Is that correct?
Yes. Usually the residents write a chunk of that note there. My note is mainly from above, where it says House Officer's note reviewed and confirmed.
And this is your, these are your notations?
Yes, ma'am. That's my note up in that section there.
And so the information with respect that the patient coded in the emergency department, these would be the residents' notes?
Right, which I reviewed as well, yes.
Tell me, doctor, would you, fair to say, you wouldn't have written this note right here about someone that could walk out of the hospital and potentially check himself into a rehab facility. Would you agree with me on that?
Not at that point, no, ma'am.
I want to turn now to James Allen. Showing the witness what's been marked as Joint Exhibit 8, page 17 to 19. Doctor, does this appear that it belongs to patient James Allen?
Yes.
And fair to say that it looks as if from the document that he was at Mount Carmel for 4 days approximately.
Yes.
This patient was 80 years of age?
Yes.
And you testified on direct about his jaundice, which is indicated right here. Does that show, that's evidence of liver failure, is that right?
His liver was not working well, is what that actually means, so yes.
Okay, when you turn towards the screen, your voice goes down. No, you're fine. Just keep enunciating louder, okay? Because it's human nature. When you concentrate, your voice goes down. So
Thank you.
And I know you had talked about this on your direct examination, but fair to say that Mr. Allen had a significant history of critical health issues.
Yes.
And and going down here to the vital signs that are noted, it says, does it not stable, and he was on vasopressors, correct?
Right, he was on epinephrine type of drip to keep his blood pressure up.
And then I just want to go back to the consultation sheet. Did you see this section here where it says plan?
Yes.
Okay. And this is drafted, or this is dictated by you, is it not, Doctor?
Yes.
You indicate here that you discussed with his son right outside of the room. Do you see that right there where my finger is?
Yes.
And you indicate that you're very concerned, did you not, about his limited reserve given his multiple medical issues and limited pulmonary performance?
Yes, he had a bad heart and a bad lungs.
And then his son seemed very realistic when I talked to him about these things. That's noted in the plan, is it not?
Yes, I knew his son from before. I met him back in 2015 when I think I met him in the ICU back in 2015. And I think his son was a paramedic or medically related person.
And so based on that fact, he had some experience with medical issues just generally.
He knew some lingo, yes.
And then I want to note this right here, is that you were the one, right, as noted in your EMR, that you discussed end-of-life issues with the son, right?
Yes, the patient was very sick and had dementia, so I'm not sure how much you would understand of those discussions.
But they clearly state they do not want to prolong the ICU course with trach and PEG if that ever occurs. Do you see that in your note?
Yes.
And then it goes on that you did talk to the son about what if it becomes a hopeless situation, correct?
Right. The plan was, in reading my note, was that we would try to fix the fixables. That's my approach to all the patients. I try to fix the fixables, let the angels take care of the rest, was the initial approach on this patient. And so therefore we were trying to fix what's fixable. If there's an infection, if we get his heart pumping a little better, if we can keep his kidneys working. But if it got to the point where everything starts shutting down, then it'd also be a heavy burden. And no one wants to talk to sons that love their father about dying and end of life. No one likes those discussions by any stretch of the imagination.
Sure, and I just want to make sure that the jury knows that the date on this service record, when you just talked about the discussions with the son, is 5/24/2018. Does that look familiar, Dr. Ralston?
Yes, it was on 5/24/2018. I did that consult, yes.
Okay, and the decision that his family made to palliative extubate him was a full 4 days later, correct?
That would be my presumption. I don't have evidence otherwise.
Showing the witness what's previously been marked as Joint Exhibit H, page 34 to 44. Again, same patient, James Allen.
Yes.
80-year-old male. Just want to, does this appear again to be your name on this note, Dr. Ralston?
Yes.
Just highlighting here, as of 5/25, would you agree with me, without pressors and critical care management, you indicated the patient would die or have organ damage?
Yes, that is a true statement.
Then going, if we could, to page 43. This assessment down at the bottom of the page, is this dictated by you?
Yes, I think there's probably more to that in general.
And then it goes up to the top of this page. Does that look familiar?
Yes.
Okay. And fair to say, right, I just want to get this down here, patient with septic shock. Tell the jurors what that is.
Shock, there's many different types of shock. There is, for example, if someone gets stabbed, they lose blood, that's hypovolemic shock. There's distributive shock, where you don't have massive infection, your blood pressure drops. But shock, the general definition of it is lack of blood supply to the end organs, the brain, the heart, the kidneys. That's the definition of shock. And septic shock is a very specific type where it's low blood pressure is caused by an infection of some sort that's overwhelming the body.
And that can be a potentially fatal situation just in and of itself.
Oh, yes, ma'am. Absolutely.
I want to go to Ryan Hayes, showing you what's been marked as Joint Exhibit 2, page 16 to 18. Dr. Ralston, it appeared to be a medical record that belongs to Ryan Hayes.
Yes.
And this was it not, overdose situation?
Unfortunately, yes.
And we could just go here. Again, this is your record, right? Dictated by?
Yes, ma'am.
According to her, the patient was not found down in water, but apparently, and then blank at that point. Did you see that?
Yeah. Yes, ma'am.
Tell me why you would have just put that blank there, or dash, or underline.
Probably very similar to here. The person taking the dictation and typing it couldn't understand me.
And then you go on to say, as typed, do you not, that the individual that found Mr. Hayes was unsure how long he was down, but it could have been as long as 5 to 10 minutes. Do you see that?
Yes.
And you noted during your direct examination with respect to the brain without oxygen and how long it takes to have an effect. Do you remember that line of questioning?
Yes, ma'am.
Okay. And the number of minutes that you said on your direct examination was what?
It varies from person to person. It can typically 4 minutes is the criteria that we use for brain damage.
And this situation, just based on your medical record and the information you were given, was that he was down from 5 to 10 minutes.
Yes, my suspicion was probably longer though, given the cerebral edema.
And let's talk about that a little bit. I want to go here before we do to this sentence right here. According to both Lisa and his brother, they clearly stated that the patient was very adamant about never being on life support, and they would not want to continue at this point. That's what the medical record indicates, does it not?
Yes, ma'am.
And then is this discussion about the organ donation, right?
Correct. The family was torn at that point, trying to decide what the patient wanted versus they knew he would want to also donate organs.
Right. And so they've got this patient doesn't want to be on life support, but donating an organ is important.
Yes.
Okay. But, and then you talked on your direct examination about the 3 options at that point, right?
Yes.
So that whether or not to facilitate the organ donation. I want to just go down to here about, you were asked a lot of questions. And I want to be sure to be as accurate as I can. About whether or not he was brain dead. Do you remember those line of questions?
Yes.
And you indicated that a CT scan was done?
Yes.
Okay. Let me find that patient. I want to make sure that we get the exact words out as to the finding of the CT scan. Fair to say that the exact words were that the CT of his head demonstrated very diffuse brain edema. Correct?
Yes.
So this is a serious situation here.
Yes.
And then with respect to the next page, so that's what the CT says. So that's the visual of the brain. Would you agree with me on that?
The anatomy of the brain at that point, yes.
And then you do this physical examination to see if there's cues that you can pick up from an examination to either support or refute the CT scan.
in conjunction with the radiology findings, yes, to see the extent of the brain damage. One's the anatomy of the brain, one's looking at the function of the brain, higher brain and brain stem at that point.
And you do that, and you know, this is when you talk about he does have bad doll's eyes.
Correct.
Okay. And that's an expression, as you testified to this juror, that you use, but it's certainly a cue that tells you that there's evidence of real brain damage. Would you agree with me on that?
Yes, the neurological exam would be very, very consistent with extensive brain damage, as with the history of the events that occurred.
And then, in line with that, you write down here, assessment and plan, do you not? I did discuss with the family that I am concerned about the severe brain injury that he has experienced and likelihood that he may progress into brain death.
Yes, ma'am, I was concerned about the brain damage and progressing into increasing cerebral edema, which can lead to brain death.
I remember during, I think it was your deposition, that you were asked these questions about brain death. And isn't it true that in your experience that you have often found that lay people use brain death or think of brain death in a more expansive way than is the true definition?
I think sometimes when you tell people about brain injury, they assume that the patient is brain dead, and so sometimes I have to correct that misinterpretation of what I'm trying to tell them. They're under stress, so they may not hear it very accurately.
And I think this goes back to the point that sometimes you might say one thing, but in your experience, given the stress and the trauma, that it could be perceived in a way that you perhaps might not be intending.
I intended it a certain way. What they hear and perceive is different, I guess, would be my statement.
That, right?
No, but you can keep going back over it, asking them what's their perception, what's going on, and try to get a good feel for what they're understanding.
Sure. But in Ohio, and so we're clear, if someone is brain dead, then they're pronounced dead. Is that correct?
Yeah, it varies from state to state, surprisingly, but in the state of Ohio, yes, if you are brain dead, you are legally dead.
That's it. And so there would be no decision have to be made whether you palliatively extubate someone or not, because they would be pronounced dead.
We don't use that term for brain death. We just, they've died. And so at that point, and sometimes that's a blessing for the family, because that way they don't feel like they're thrust into this decision-making role.
And it relieves them of that decision, right?
The burden, yes.
This is a good place to break.
Sure, Judge.
Okay, ladies and gentlemen, I'll give you 5 extra minutes. We'll start back at 3:15. Okay? Have a wonderful break. Remember the admonitions. And be gentle on David talking to him, okay? I know you all want to talk right away. Give this man a little bit of time. Okay, doctor, remember the admonition. You can go ahead and step off. Mr. Zion, anything for the record? No, Your Honor. Ms. Menashe,
Yes, Judge?
anything for the record?
No.
Okay. 15 after.
Oh, okay. I'll go back.
Yeah.
Just the 3 side discharges.
You want it? Oh, this doesn't do here.
Channel 10 feet. You two, since no one else is here, I want to put a camera on you right now. Channel 10. You channel 4? You got the curve. Never again.
risk of setting down during discussions.
Sorry. I got an extra one up here.
All rise. Thank you. Please be seated.
Ladies and gentlemen of the jury, I hope you had a wonderful break. We're going to continue on with the testimony. Ms. Menashe.
Thank you, Your Honor. Just closing out the line of questioning with respect to Joint Exhibit 2, page 16 to 18. Doctor, this consultation note appears to be from 4/2. Would you agree with me on that?
Yes, ma'am.
And again, the discharge date, as noted, is 4/4.
Yes, ma'am.
And as indicated, this last line here says, likely he will require brain death testing tomorrow, correct?
Yes, ma'am.
So in 4/2, that was the state of peril that this individual was in.
Yes, he was very brain injured, but not brain death at that point.
I want to move now. Did the prosecution have you, in advance of today, review Mr. Hayes's medical records as a whole from 4/2 to 4/4?
Mainly my role in the physician's progress notes, things like that.
You would agree with me, would you not, Dr. Ralston, that with respect to Ryan Hayes, the family actually made the decision to palliatively extubate Mr. Hayes during the day shift?
I don't recall that. I'd have to look at the records again.
One moment while I get something to refresh your recollection, and I will move on in the meantime.
My partner was on the next day. I did not see the patient the next day.
I want to move to the next patient, Ms. Belisari, showing you what's previously been marked as Joint Exhibit 1, page 126 to 134. Or, I'm sorry, 134. Doctor, does that appear to be medical records belonging to Joanne Belisari?
Yes, ma'am.
And just so we're clear, that's your name on that medical record. Is that true?
That's correct.
When I go to page 2 of that, right here, I want to just say, discuss the record that you indicated under comments. It says, does it not, discuss with sister at bedside, discuss with them the fear that she may eventually tire out and require intubation. Do you see that?
Yes.
And this note is from 4:30?
Yes. Again, this, I apologize, it's a format that I'm not used to seeing.
Sure.
I'm used to seeing on a computer, so.
And so if I could just orient the jurors with respect to timing, this indicates it's 4:30, and based on the admit date, she had been at Mount Carmel for, let's say, 8 days-ish. Does that sound right?
Yes.
And her discharge date, assuming that's the date she passed, is a full 11 days later on May 10th.
Yes.
Going now to hand. This sentence right here, page 3, that sentence right there that starts with intubated, what did you indicate in the medical record right there, doctor?
She was intubated on life support and blood pressure support. Cachectic is a term that means she looked like she had lost weight, looked thin in general.
And she's on full life support, as noted in your medical record, correct?
Yes.
And when we see house officer, based on our prior discussions, we know that's you.
That's the resident.
That's the resident.
Young doctor. The old term for them was house officers because they spend all the time in the hospital, so they were in house or whatever.
So would you agree with me that this note right up here indicates critical care 42 minutes, without ventilator or pressors, patient would die? Do you see that note?
Yes.
And I remember you testifying on your direct examination when you said because without life support, there is no longer life supported. Do you remember that?
That would be correct, yes.
Let me go back to Mr. Timmons, if I could.
Okay.
Sorry to jump around, but were you, doctor, on the critical care committee
Yes.
during this relevant time frame?
Yes.
And did the Code Blue committee report to the critical care committee?
Yes.
I want to ask you about codes then, and what you would know about the coding process at the hospital. Tell the jurors what a Code Blue is, based on your experience.
Sure. Code Blue is an alarm that basically overhead, you've probably seen on Grey's Anatomy or whatever, there's a Code Blue that's called out. That means a patient's heart has stopped somewhere in the hospital, or even somebody needs help. The ICU physicians and or residents come into the room. There's pharmacy that comes. There's anesthesia that typically comes. There is nursing staff. ICU nurses come and respond. And you try to, following American cardiology's recommendations, you follow what's called ACLS, Advanced Cardiac Life Support, and you try to get the heart restarted by beating on the chest, by ramming a tube down their throat or placing a tube down their throat, and shocking the heart if the heart rhythm is one you can shock and bring back.
By analogy, in your experience in critical care, if you're on duty and the blue light or a code is called, and you're the physician, are you essentially the orchestrator?
It depends. Multiple people are qualified to lead a code or follow ACLS guidelines or ACLS qualified. The house officers a lot of times run it. I try to intervene if they're making a mistake or not thinking of something. But yeah, either myself or the house officers or even the hospitalist can actually run a Code Blue as well, or cardiologist, for example, as well.
And we know from your testimony on direct that after 2013 to 2018, residents or house officers didn't work in the night shift, correct?
That is correct.
Bless you, Sam. So just want to show you, again, going back to Mr. Timmons.
Your Honor, I would object if this witness was not present for these medical records.
Okay, let's start a sidebar here on this one. Get to know each other.
I didn't say anything. I didn't know that.
Just sidebars are not my favorites. I'll ask a different way.
I won't take it personal, so it's okay.
And we've known each other too long, so you can't. Dr. Ralston, with respect to Mr. Timmons, you indicated that you reviewed the records with these patients that related to you. Do you have recollection as you sit here whether Dr. Husel performed any codes on Mr. Timmons?
Object, Your Honor.
She can answer that one.
No, there's obviously several codes throughout the year in a hospital from many years ago. I would not recall that.
And so I remember on your direct examination when you were asked about codes, fair to say that some people survive them and some people don't.
Yes, that would be a true statement, yes.
I want to go to the issue, some general issues. Let's talk about overrides. I know you state on your direct that the nurses do what the nurses do.
Yes, ma'am.
And same thing with respect to overrides. Dr. Ralston, you, during this relevant time frame, 13-18, had no idea about overrides.
No.
And so it would surprise you to know, would it not, that let's say during the year 2017, there were over 36,000 overrides on the ICU floor at Mount Carmel West.
I wouldn't know what's normal or abnormal. That's a pharmacy and nursing thing. I would not know whether that's high or low.
I want to talk about order sets, showing the witness what has previously been marked as State's Exhibit 17A. Dr. Wilson, does this look familiar to you, this document at all?
Yes.
Okay. And what do you know this document to be?
It is the terminal or compassionate extubation order set.
Fair to say that during your interview with Columbus Police Department, you were asked about whether you use order sets, correct?
Yes.
And during the years 2013 and 2018, fair to say you did not use order sets?
Typically not, but I did forget about the residents. If the residents were on, sometimes I'd show them it and show them what's on it, things like that.
Right. But you, in your care, when you decide, when a family decides, and you were overseeing a compassionate extubation, as you have told the jurors, you weren't using an order set, correct?
That's correct.
I want to talk about, going back to this point about the nights. I think we talked about what it looks like visually at the hospital at night. Wanted to ask you about the convenience, and that word seems kind of gross to use in this context, but you would agree, would you not, that actually sometimes it's more convenient for families to do a nighttime palliative extubation because of scheduling, would you not?
Convenient in the sense of perhaps in the early evening or late evening. I think it's challenging when I'm not necessarily thinking that well at 2 o'clock in the morning sometimes. I think it'd be hard sometimes for families to be that early in the morning.
Sure, but when I'm a family making a decision to palliatively extubate and it's 8 or 9, then in the nighttime, and I know you were asked this during your deposition, it can give an opportunity, right, for people to come in from out of town because you want that.
Yes, ma'am.
And so, and also in terms of, I know I asked you whether there were any rules against nighttime extubations, and we know there weren't.
That's correct.
I want to talk about the number of compassionate, as you call them, extubations that you've done. I know in your direct you testified that with COVID, you're now hovering around 1,000, and
Right.
yes, won't
It's a
make it
guess.
an exact number. But fair to say, when you were deposed in 2020, you gave an estimate that maybe you did around 20 or 30 a year. Do you remember being asked that question?
Yes, but again, these are guesses. I have no idea.
Sure. And I just want to kind of give that.
And I apologize. I thought it was over my career, not just in that time frame.
Okay, so between 2020 and now, you've done how many palliative extubations?
I'm sorry, between 2020 and now?
Yeah.
I don't know. Way too many. I guess with COVID, it's been devastating. We're probably doing maybe 50 or 60 a year. Personally, myself, not just my
Sure,
partners,
sure.
so probably 50 years or so over the past year.
Okay, so, and that's not my forte. So, an estimate, not looking into it, 1,000 over your career. And tell me again the number of years of your career.
1997 through 2022, so it'd be 25 years.
Okay,
Well, excluding my fellowship training, which is additional 7 years, so gosh, 32 years.
okay. And I had just done the math on 25. Okay, so it's about 30 plus a year. Does that sound about right?
That sounds a guess, yes, ma'am.
Okay. And if you know, as the director of the ICU at Mount Carmel West, does it sound about right that in Dr. Husel's 5 years, he did just 35?
That would not seem extreme to me, no.
Just a few other questions, Doctor. During your deposition, you were asked about the IV guidelines. Do you remember that?
Yes, ma'am.
And whether you were familiar as of 2020 with the IV guidelines, and you indicated that you were not.
No, ma'am.
No.
I was not aware.
One moment, Your Honor. I forgot to ask you, Doctor. When you were asked about these order sets, and I'm just showing you as an example, State's Exhibit 17A, do you remember referring to these order sets as checkbox medicine?
Yes, I think when you're doing a very difficult approach to medicine, you try to take into account the patients, the family, all these other variables that come into play. I want to give the best care to that patient, even if I'm compassionately extubating them, and I don't like people get in the habit of just using the same thing without thinking about the patient as an individual in general.
And I remember you saying in one of your statements that the human body is an amazing thing. Do you remember saying that?
Yes, ma'am. I think it is.
And to that end, I wanted to ask you about the conversations that you have with families when they're making the decision as to changing the code status and palliatively extubating their family member. Fair to say that you talk to the families and you tell them that once their loved one is palliatively extubated, that the patient could last moments,
Yes.
they could last minutes,
Yes.
hours, days,
Yes.
and you would agree with me that even moments could be less than minutes.
Yes.
Nothing further.
Redirect.
I didn't have a look at the 17A. Thanks.
Still have one on the screen.
cross-examination, directing your attention or redirecting your attention back to what Ms. Menashe said about the total number of critical care patients or critical care doctors at Mount Carmel West.
Yes.
And she referenced a number of 2,300. That's not correct. You said you didn't know where that number came from.
That is correct. I know most of the critical care doctors. Yes, sir.
Right. Is it fair to say that within the 4 hospitals, you are aware that Mount Carmel has 4 hospitals in its chain?
Yes, I practice at 2 of them, actually.
Okay. Is it fair to say that there could be up to 2,300 physicians with prescriptive authority within those 4 hospitals?
Yes, that would probably be reasonable.
So if there's a number floating out there, 2,300, that would be the doctors that can write prescriptions for things like fentanyl and midazolam.
Objection as to speculation?
I think you can answer it.
I'm sorry, could you re-ask the question then?
So if there is evidence that there is approximately 2,300 physicians in the Mount Carmel hospital system, the 4 hospitals, those doctors would have prescriptive authority to write prescriptions for things like fentanyl and midazolam.
Yes, sir.
All right. Directing your attention to Ms. Menashe's line of questions regarding complaints about Dr. Husel in 2013 to 2018 until you became mayor in November of 2018. Did you have any knowledge of his dosing habits during palliative withdrawals in the nighttime at the ICU?
No, sir.
Had you at any point become aware through any of your review of anything that went on in the ICU at night that he was giving 1,000 micrograms of fentanyl in an IV push to patients in the ICU during palliative withdrawals?
No, sir.
Referring back to the line of questioning regarding the pharmacist call, you said, I'm a human, I make mistakes.
Yes.
So have you ever added an extra 0 onto something, for instance?
I'm sure I might have, yes.
Is that the type of thing you're referring to, making a mistake, a pharmacist calling you?
Yeah, or either the dose or the type of medication, or hey, this patient's allergic to this, or there's this drug impacts that drug. Are you aware of that? Those are important patient safety issues. Yes.
Okay. When you were saying about when the decision's been made to compassionately extubate somebody after this planned event with the family, you say you entered it into the computer. Tell us about that. What does that mean? Can you describe that more fully?
Sure. What I do is I basically just the computer component. Is that correct?
Yeah. Tell us how you do that.
Okay, I would just sit down in front of the computer. I would put the order in. I'd make sure that the DNR CC is put in at that point. I would make sure that the medications have been entered correctly. I would probably, or I always go to the bedside nurse and say, hey, I put in these orders. When the family's ready, let me know. We'll get things going or whatever. Let me know of the timing so when I need to come back, or usually I don't leave the ICU in these circumstances.
So there's no rush.
No, there's no. I'm trying to make sure that, of all things, make sure these orders are put in correctly. Yes.
Okay. Referring to 17A, which was just up there, this has been identified as the order set for palliative extubation. It's called terminal ventilator withdrawal. Is that another word for what you call compassionate extubation?
Yes, that is correct.
Okay. And you testified with Ms. Menashe that you don't like using, or you refer to this as, what was it, cookie cut, push button?
Checkbox medicine.
Checkbox.
I was raised in the era of we actually wrote out every order and things. So.
Okay. Well, let's look what's in the order set compared to what you testified is your general practice. What is, referring to medications. What is the range of medications that is on this order set?
One, the first morphine order there, the 10 to 5 dose, one's 10 milligrams or one's 5 milligrams. That's prior to take the breathing tube out.
And that's a case by case, that says PRN situation?
That's the second orders there where it says morphine, the second morphine order, the 1, 2, 3, 4, or 5.
Okay. So this would be what the order set would call to start with?
That's prior to taking the breathing tube out. Yes, sir.
All right. Is your practice in line with what the order set is?
Objection, Your Honor, beyond the scope.
She showed him this.
Permit
I'm sorry?
it. I'll permit it.
Oh, thank you.
Yeah, it's a little lower than what the order set says, yes.
What's a little lower?
My use of the morphine.
You actually use less than this.
For the prior to extubation, yes, but afterwards, that's about what I would use in the first hour.
So this second, I guess in medications, it would be the third check box down.
Right.
This is the PRN stuff?
Right, I'd use 2 milligrams every 15 minutes for any perceived distress from the patient.
Okay. And that's what that inject Q 15 minutes, that Q means?
Q means every 15 minutes as necessary for shortness of breath.
All right. And this would be the first hour post-ventilation?
Right, and then after that first hour, you're supposed to come back and reassess the patient and see if they need more or less or nothing more or anything like that.
All right.
That's the third morphine order.
That's down here?
Yes, that's if you see comments after first hour after the endotracheal tube or patient's extubated withdrawal.
Okay. And it goes on. What about Dilaudid? Per the order set, do you give Dilaudid and morphine together?
I'm sorry, I can't quite see that. I
I'm
apologize.
sorry. It's on the second page?
You don't really need the two classes of the same narcotic.
Okay. And is it ever been your practice to give, and Dilaudid, another word for that is hydromorphine, that's the generic of that?
Yes, sir.
Has it ever been your practice to give both morphine and Dilaudid together?
No, because they're both narcotics.
Okay. So what's this next checkbox mean versus what you do? This down here.
Objection, same objection, Your Honor. Beyond the scope, it's the way he does.
Okay. I'll note the objection overruled. But you got this thing all open up. You can't see what you're referring to.
Gosh, Judge, I'm not
Thank
right
you.
here.
I was going to ask that.
I'm talking about this right here, pointing to the middle page of the second page of 17A.
That is for morphine drips, which is a slow drip of morphine into the vein continuously instead of pushing it in all at once.
Okay. And this is another thing that can be checked. And what does titration mean?
Basically, it's to adjust the medicine up or down based on the patient's symptoms.
Okay. And then after the morphine, there is this Versed section.
Yes, that is correct. If you bring it down just a little bit, we'll see the first
sorry.
one there.
And so the Versed, or also known as midazolam, is also on the order set, and I think you testified that it is also your practice to give a dose of Versed.
That is correct.
And it starts at 2 milligrams per the order set?
Yes.
And is that your practice as well, generally?
Yes.
All right. And then it goes on to explain how Versed, is that fair to say, gets continuously given?
If you could pull it down again, I apologize.
Yep, sorry.
Yeah. Yes, if the other one is Versed for a Versed drip.
Okay. And the drip is the bag of?
A bag of fluid with Versed, the chemical mixed into it, dripping into the IV.
And is that slower than pushing it in all at once?
In theory, you have less of the dramatic effects that way. It'd be slower effects, or slower of the side effects that way.
And what side effects are those?
Objection, Your Honor, beyond the scope.
Sustained on that one.
What about oxygen therapy and the order set versus what you do?
Yes, you tip.
She asked about the order set versus what he does, Judge.
Right. I'll give it to you on that one. You're not getting an opinion, so.
You place a patient on the nasal cannula oxygen. You might see people at the grocery store wearing the plastic tubing in their nose. And that's mainly for comfort a little bit. Oxygen is actually a drug, and it does provide some comfort at the end of life as well.
And it's on the order set we see here in 17A. Is that also your practice?
Yes, I always put in specific how much oxygen. The order set doesn't address that, so I always put in how much oxygen I want them on in general.
Because you don't want to do this checkbox medicine. You're looking at your patient.
I've been asked and answered several times. You were to strike the questions, granted.
All right. Ms. Menashe asked you, she said, can you give us 5 of the factors, or 4 of the factors that go into dosing, your dosing decisions for patients during palliative extubations? And you said, well, I don't know if there's 4, there's maybe 5. Do you remember that?
Yeah, there's probably multiple beyond that.
All right. My hearing's not so good. I got number 2 is brain.
Yeah, what's going on with the brain in general? Is it damaged? Is it even capable of perceiving pain at that point?
Okay. So with Ryan Hayes and his brain being damaged that Ms. Menashe talked about, did he need more pain medication or less pain medication based on what you saw when you saw him and when you made that note?
He required less pain medication or no pain medication at that point.
I think number 3 was age.
Yes.
So we saw in these examples of the patients that you cared for, some of these folks were very, I have to be careful, they were elderly. Some, I believe Mr. Allen was 80.
Yes, I like to say older, not old, is what I always say.
And I understand that now as I reach those ages here. So how does that affect pain dosing? If someone's older, do they get more medicine? Do you need more pain medicine, or do you give them more pain medicine? Or is that something that will factor into giving them less pain medication?
Objection, Your Honor, beyond the scope.
Well, you did elicit it. I'll permit it.
As you get older, you need less pain medication in general because the older brain doesn't handle it quite as well.
I wrote down number 4 of the factors of the 5 you gave, liver/kidney function. Can you explain why that is a question or something you would like to know determining how much pain medication someone requires or you prescribe?
You want to make sure that even if you give the pain medications, you want their liver to be able to clear it at least, or the renal function not to let it keep accumulating is the biggest fear.
So if someone's liver and or kidney function is compromised, as we saw in those patients that Ms. Menashe pointed out, does that mean they should get more pain medication?
Your opinion, you've gone through this.
The way your question is, she's right. Sustained.
Based on your experience with these patients, if their liver function was compromised, if their kidney function was compromised, on your experience, would you give them more pain medication or less pain medication?
In my practice, I would wind up giving them less.
What was number 1? Do you recall? And I'm honest, I just didn't write it. I was trying to write it down. I think brain, age, liver, and then family. What was number 1, if you recall?
I thought it was brain, so I apologize. I'm not sure. I think disease process is what I put in there, disease process.
Disease process. What does that mean, and how does that affect your decision on dosing levels for pain medication and or benzodiazepines?
I think it was pain, how much pain the patient's in, I guess, that's what I put, I think, actually. I apologize. or perceived pain.
And how do you determine that, and how does that affect your dosing decisions?
I think looking at the patient, what caused them to be in life support to begin with, what an overall view of what's going on with the patient at that point. I think examining the patient to get a feel for if they're in pain or not. Myself, I think that's the key.
All right. So in your practice, that is a decision you examine the patient and make a decision about.
Yes, I think that's an important role of the ICU physician, yes.
All right. And finally, you said family. Mm-hmm. Explain what that means and explain how that affects your dosing decisions regarding how much pain medication and or benzodiazepines they need.
Well, I think I did a pediatric residency also with internal medicine, and so I was always taught to look at the family as a unit from my pediatric training. So when I look at the patient and the family, they're a unit together. They're all kind of going through this together. And so basically, I want to say, when I stop back by, I always ask them, how do you perceive the patient's doing? How do you feel about how the patient, do you think that your loved one is hurting, or you know them better than I do? I mean, the answer would be yes. If you need more pain medication, we can make sure of that. But obviously, their input matters in those discussions when I'm coming back checking on that patient.
All right. Do you recall the questions regarding the statement Ms. Menashe made and the questions she followed up with? Two doctors with similar backgrounds and experience can have different views on how to treat a particular patient.
Yes.
Okay. And you agree that, yes, that is a valid thing.
In general, yeah, it's hard to argue with that statement, yes.
In particular, in this case, in 2015, how many years experience did you have?
I'm sorry. Let's see, 2018 years maybe, if I exclude internship and residency and fellowship. So
In 2015, how many years of experience did Mr. Husel have?
he would have 2 years at that point, if I did the math correctly for him.
James Allen, I think we based on his practices, his dosing.
Well, he also treated the person involved as this witness not permitted.
And you also said, based on what you treated him on and what you were crossed on, he had significant health issues and limited pulmonary performance?
Yes, he had pretty severe COPD and got short breath walking very short distances.
And so, in your experience, is that one of those things you look at in deciding to give more pain and benzodiazepine medicine or less pain and benzodiazepine medicine?
Objection, Your Honor. Same objection.
Same. I understand. I think you can answer it. Go ahead.
I would probably wind up giving him less at that point.
Ryan Hayes, the overdose situation, down for a long time. That line of questioning, remember that?
Yes, sir.
I don't know if it was Ms. Menashe or you, state of peril on 4217.
I'm sorry?
Do you remember that phrase being used in describing Ryan Hayes? He was in a state of peril on 4217?
I don't remember that. Almost all my ICU patients are in a state of peril.
Yeah, I guess so. But he had been down for a long time, correct?
Yes.
He had a severe cerebral edema.
Yes, the brain was swollen. Yes, the top part of the brain.
Your note reflects that based on your experience with this patient, he cannot perceive pain, he cannot perceive anxiety.
That is correct.
Based on your experience in dosing patients in this state, is that one of those factors where you would give him more medicine, pain medicine and benzodiazepines, or less?
Less.
Miss Belisari, do you recall how old she was?
No.
69, 61, exactly. Was it 69 she was?
She told the jury already, so I think that's good.
Let's see. If the records reflect, let me get to it here. She was born in 1945. So in 2015, how old would that make her?
70?
Okay, he's here as a doctor.
I know, and I'm sorry. So that's 55 in 2000 and then plus another 15, so that would be 70 years old approximately.
Yes, sir.
I think the medical chart said 69, but
All right, she hadn't had her birthday yet? So once again, and not, is that a person that's older in your mind or younger in your mind as far as the dosing of pain medications?
I wouldn't, I'd have to know more information. I don't know that.
Well, we know that Ms. Menashe pointed out to you that without life support, the patient would not survive.
Yes.
She was critically ill.
Yes.
Is that one of those factors where you think, well, I need to give her more medicine or less medicine?
Objection, Your Honor, he wasn't there. This calls for an opinion.
okay.
He's already said he would have no more.
Got it, sustained.
You did cover the night shift a few times in the ICU in your career?
Yes.
All right. Do you recall ever doing palliative extubations at 1, 2, or 3 in the morning?
No, sir.
Why are you looking at those 5 factors in determining the amount of pain medicine and benzodiazepines to give your patients?
Your Honor, I think it's misstating the witness's testimony. It wasn't that there was just 5.
Okay. It's also asking him to opine, so
In
sustained.
his practice, why does he look at
That
those?
wasn't what you asked him.
In your practice, why do you look at those 5 things?
Objection.
I'll permit the answer.
Because in medicine, you don't want to even be perceived as crossing that line of
What line is that?
Now you're getting into a different subject matter here.
All right, I'll withdraw that question and let him answer the question.
Which question?
Why does he take into account those in his practice, those 5 things he described on your cross-exam?
You don't want to be the physician that caused someone's death where you cross that line or even perceived to cross that line of causing their death with your medications, and you don't want the nurses or anybody to feel guilty about giving those medications either.
Thank you. I have no further questions.
Anything on the last statement?
Yes, please, Your Honor. I would also ask for a recross on 2 other points. If you want me to approach sidebar.
Let's approach sidebar. I know you all hate it.
Yep,
These guys love it.
seems necessary. Can I have the orders?
When I use the 17,
Great. 17A, you could offer my questions.
They don't go entertain. They're quiet over there. I'm getting worried. Oh, go sliding across the floor. You ready?
One moment, Eric. Doctor, just a few questions. If I may approach with State's Exhibit 17A. Doctor, if you could review that. And again, fair to say that's an order set?
Yes.
If you could just flip through the 3 pages and let me know if there is any box within that order set to check for the use of fentanyl.
There's not.
Don't waste one of your questions.
Just stop myself.
Okay, I'm proud of you.
It's a little thing. You were asked a line of questions about Ryan Hayes and the 5+ factors you would consider when determining the pain medication for a patient like that.
Yes, ma'am.
Would it have impacted your decision-making in any way, showing the witness what's been marked as Joint Exhibit 2, page 205, that 2 different nurses seem to have indicated that Ryan Hayes, the patient you've discussed, had a pain score of 10?
I apologize. I thought pain score went to 8. I apologize.
Right, and so, and let me look, Your Honor.
Wait.
Okay, so then I would just ask the witness didn't answer my question. Would it have impacted your decision-making in any way that 2 different nurses have indicated that his pain went from 0 to 10?
Knowing his physiological process at that point, I would have to come and look at him myself.
You would need to be at bedside.
Yes, ma'am.
Nothing further, Your
Third
Honor.
question, huh?
Nothing further. I'm always dancing.
Okay. You may step down. Do you have another witness ready for us?
We do, Your Honor.
Let's call the next witness.
Calling Dr. Caleb Wagner to the stand.
Judge, with your leave, I'm going to step out
Okay.
just to...
Make sure that the good doc gets out of here good. Or well, actually, if I'm going to be grammatically correct. You guys holding up okay? Is it warm in here or is it just this robe? Like the opposite? I am roasting up here, guys. It only comes in, the heavy material. Come on down, doctor. Good afternoon. Follow that gentleman there, and he'll get you to where you need to go.
Raise your right hand. You swear or affirm to tell the whole truth and nothing but the truth, so help me God?
I swear.
Thank you. Please take a few seconds to consider yourself comfortable.
You can lower your mask, it's fine. I want you comfortable.
And if you would be so kind as to state your name for the record and spell your name, please.
My name is Caleb Wagner, Caleb Wagner.
Can you guys hear him okay? Okay. You got that aerial mic in front of there. You have to blow it out a bit. Okay? Knock them down.
I can do that.
Okay, deal. I expect no less.
Thank you. Thanks for coming this afternoon, Dr. Wagner. Can you talk a little bit about your education and training?
I did my undergraduate degree at Ohio State University, and I graduated in 2006 with a degree in the biological sciences. I went to medical school at St. Matthew's University, and I did my residency training in internal medicine at Mount Carmel West. I finished that in 2014.
Other than medical school, have you ever worked as either a medical student or a physician at any other institution other than Mount Carmel West?
After I finished residency, I did a brief stint at Adena Healthcare System, and I only lasted about 9 months there before I returned to Mount Carmel West.
Thank you. And sir, what is your position at Mount Carmel West?
I'm an internal medicine physician. I'm employed with a group named Columbus Inpatient Care, and the group I work with is contracted to provide hospitalist service in the Mount Carmel Health System.
Thank you. Talk to us a little bit about your role as an attending at Mount Carmel West.
Working as an attending, to give an example, our group of doctors function as something that like perhaps your outpatient family doctor would do, except we do it in the hospital only. We're all internists. Typically what we'll do is admit patients from the ER or direct admit patients from home with a variety of medical conditions, even sometimes some surgical conditions. We'll still be the main admitting team sometimes. And we care for a variety of illnesses, so it's hard to describe just one.
What were your assigned responsibilities for a patient if you were designated as the attending?
Typically what that would mean is performing the H&P, monitoring their care.
Does that mean that the initials, the H&P?
Oh, the initial evaluation, we call it a history and physical examination. It's a long note where we describe why the patient came to the hospital, what they were sick with, what we felt was going on. We correlate lab findings, test findings along with that. We include a physical exam and as well as imaging. It also includes a synopsis of the patient's past medical history and surgical history. And then essentially the last part of our note is where we make the diagnosis for why they're in the hospital and what our plan is going to be to start treatment for that patient.
Do your responsibilities vary depending on which shift you work?
They do. They can vary greatly.
Okay. Did the jury hear that, the question? And what shift do you normally work?
I work essentially 2 different shifts in the Mount Carmel system. I work what we call days and nights in our group. So I'm either what we call a daytime person, 7 to 3 time frame, where that can consist of either rounding on patients or just being what we call our admitter, where we admit all the patients to the hospital. And then I'm one of the docs in my group that does about 8 weeks of nights a year, and that is coming in around 11 p.m. to 7 a.m. And that role is admitting patients to the hospital, evaluating patients emergently on the floor if they're having new issues, and sometimes what we refer to as just putting out fires, maybe problems that are occurring that did not expect to occur, or new situations in the hospital, to give an example.
Thank you, doctor. Now, when a patient presents, how are they assigned an attending physician?
Typically, most common example is patients will come through the ER. The ER physician will see them, evaluate them, and the ER physician typically makes the decision of, can you go home or do you need to be admitted? And once that decision is made, the ER typically contacts our group, and then we take over the care and go and evaluate the patient and start their hospitalized process.
Okay. And so just to summarize, it sounds to me like these patients aren't patients that you are seeing in the community. Is that correct?
That is correct.
Okay. Is there ever a continuum of care with them when they're discharged from the hospital with your group?
Typically, no. What's done is our care is handed off for the outpatient physician. Typically, they're often referred to as a family physician or an internist. We hand that off to them essentially at that point.
Okay. Do you, as an attending physician, have duties relating to the discharge of any patient?
Yes.
And what are those duties?
The duties of the attending physician at discharge are to, I'm trying to give an example here. So if someone is sick in the hospital with a heart attack, the cardiologist might do some of their emergent care and make recommendations, but the attending's job is to make sure they have their medications they go home with, that we write the note to, sometimes referred to as a discharge summary, which is a summarization of why they're in the hospital. And this note lands back with either their main doctor and the outpatient specialist they may end up seeing sometimes for a summarization of why they're in the hospital and a synopsis of what they were cared for, what they were diagnosed for, and maybe what needs to be followed up or tests that might need to be performed in the future.
Thank you, doctor. If a patient is critically ill and is moving to a DNR-CC, is the attending part of that discussion typically?
Sometimes.
Okay. And what would determine whether the attending would be or wouldn't be?
That's a very situational question. Sometimes it can be done by the ICU team. Other times, if it's a patient on the floor who's not doing well and maybe doesn't want to go to a higher level of care like the ICU, sometimes that's where the attending would have that discussion too as well.
Okay. And would you expect as an attending to be called in that situation if you were in the building?
Not always.
Okay. And what would drive that?
Typically, if you want to take an example, if I'm covering nights, typically it's if a nurse contacts me with something, say it's a floor patient who's not doing well, they would ask me to come evaluate the patient, and then either the patient or family might have a different desire, and that's where we would start talking about code status and how aggressive to be, and we'd have some of those conversations centering around a DNR.
Okay. If a person's on life support and withdrawal of that same is being discussed, would you be in the discussion?
I've had that discussion before with families. It's usually when I'm a daytime physician, I'm calling it, where I'm rounding in the hospital, seeing patients. That discussion also happens a lot with our ICU team as well.
Okay.
And there are other services at the hospital, like our palliative care service, that sometimes helps us assist having those discussions because they're not easy discussions to have.
I'm going to hand you what's been marked as State's Exhibit 6B. Dr. Wagner, what is 6B?
The 6B is a discharge summary.
Okay. And is there a patient indicated on the discharge summary?
Yes, this is for patient Francis Burke.
Okay. And I see that according to this, Ms. Burke was apparently discharged 1/14 of 2018. Is that correct?
Correct.
Okay. Here's page 1, second half. Page 2. And page 3. tell us what page 3 denotes as far as this lady's status at discharge?
The page denotes that she's deceased.
Okay. Did you prepare this discharge summary?
Yes, I did.
Did you ever meet this lady?
No, I did not.
Did you review her entire medical record?
A brief synopsis of it.
Do you know what happened to her in the hospital?
From review of the chart, I'm aware of what happened to her.
Can you tell the jury what her course was?
She came in the late afternoon, and I was working our night shift then, and I would only be speculating as to why she wasn't seen by.
Okay, you can't speculate about something, so we're going to stop you where you're at, and we'll let her ask more questions for you.
Okay, I'll withdraw the part of the question that calls for speculation. Did you review the medication administration record in this case?
I reviewed it when I was summoned to hear.
Okay.
That's when I saw that.
Did you review it before you created the discharge summary?
No, I did not.
Okay. Sir, I'm going to hand you a document under seal marked
Objection, Judge.
State's Exhibit 18F.
Let's go talk here. Talk, guys. David, you need to give me a recipe for baklava.
Exhibit 18F. Ask you, if you could tell us what it is.
This is a death certificate for Francis Burke.
Okay, stop. Let me explain something. The word sealed is one of those words that people think it's got this big mystery to it. It's just a document not available on public record. Okay? There's nothing special about it. In this case, she explained what it was. Okay? I don't want you getting the wrong impression of the word sealed. Okay?
Actually, can you have another sidebar?
What did I get wrong?
I'll withdraw the request. Did you sign this?
No, I did not.
Okay. Did you prepare any forms for a death certificate for Francis Burke?
No, I did not.
And why is that?
I never saw Francis Burke.
Okay. And does that create an impediment as far as creating the death certificate?
I never did an exam on her. I never saw her. And this occasionally happens, and sometimes the death certificate is sent off to either the family doctor or someone else.
Okay. Do you know who did the death certificate in this case? Do you know that individual?
I do not know that individual.
All right. Dr. Wagner, one question relating to your previous testimony about the MARS in real time. Was there some reason why you didn't look at it?
I had no reason to question her medication she was given.
Okay. And just for the record again, the MAR is what?
Medication administration record.
Okay, thank you.
Mr. Baez?
Good afternoon, Doctor. You have no independent memory of when you actually did this discharge summary, correct?
No, I do not.
In fact, you didn't even look at it or have any idea that this was ever going to be an issue until you were called to testify in this case?
Correct.
And obviously, since you never saw her, you don't have any memory of Ms. Burke or her care.
No, I can really only comment on what other doctors documented.
And fair to say some discharge summaries are more detailed than others, right?
Very, very fair to say.
Okay, and that's just like patient, that's just like patient care. Every patient is different. Is that a yes? Yeah.
Yes.
Say yes to the court report.
Yes.
Okay, so, and in this one, you would classify this one as one of the lesser detailed discharge summaries.
This was a very atypical discharge summary for me.
You never, there was never anything preventing you when you did this discharge summary from looking at the MAR, and looking at all of the electronic medical records in Ms. Burke's care.
No, nothing prevented me from looking at it.
And there's nothing, and you never sent a notice to anybody, hey, I never looked at any of this stuff when I wrote my discharge summary, correct?
It's not normal to do a forensic review of the chart for a discharge summary.
But my question to you, sir, is you never notified anybody, any doctors, anyone in the hospital, hey, I didn't look at the MAR or I didn't look at any of the charts.
Well, I did look at her chart.
Excuse me, I misspoke. You didn't notify anybody that you didn't look at it, correct?
I guess I'm not sure how to answer that. I don't normally notify anyone if I...
You wouldn't normally do that, right?
No.
And that's not something that is in any way, shape, or form the normal course of business, right?
Can you ask that again?
Sure. That's not in any way, shape, or form the way you would normally do a discharge summary.
Normally when I do a discharge summary, I've usually been involved in the care at some point, and typically I write much more than what I wrote in this discharge summary.
I have no further questions. Thank you.
Redirect? You can step down.
Sorry.
Sorry, Judge.
Sorry.
I forgot. May I
That was me.
check, see if I have one more question?
Do you have one more question?
No further questions.
No further questions then?
No, Your Honor, thank you.
You may step down, Doctor. Thank you. Call your next witness.
I believe we're out of witnesses
Okay.
for the day, yes. Not for the case.
I guess we were more efficient than anticipated. Ladies and gentlemen, I'm going to have to send you home early. I'm sorry. I know you want to sit here with us the rest of the day, but, remember the admonition? Be sure you all speak to David about the other issue. Okay? I imagine I'm going to have a bunch of emails tonight, so let us know, guys. Okay? With that, call them up, David.
All rise.
Have a good evening, guys. Be safe. Be seated. Ms. Grubb, anything for the record?
Yes, Your Honor. I would like to put one thing on the record. During Ms. Menashe's cross-examination of Dr. Ralston, she referred to a deposition. We do not have that deposition, nor was it supplemented to us. I believe that's the third time that the defense has used materials that have not been forwarded to us in reciprocal discovery. I just want to make a record. Thank you. And ask that we receive all items in the future.
Ms. Menashe?
Yes, Your Honor, I'm happy to give them a copy of the deposition now, and I can just say the only reason why I wouldn't have or thought to have is because they have seemingly had all the civil deposition transcripts through their joint agreement. So I certainly didn't think that we needed to provide a transcript in the civil case today.
Well, why don't you check with them? If you're going to use something, make sure they have it ahead of time.
Sure, I will.
I mean, it's hard to do that, I know, and we may have to play it by the fly, but, try to at least get it over to them.
Sure,
Your
we'll do
Honor,
that.
if I may address the record, we do not have a joint agreement with any civil attorneys. As a matter of fact, we piecemeal the items that we receive, and we are supplying the defense with a full list at the beginning of each week of which witnesses we intend to call. So I don't think it would be onerous for them to check off with us to see what depositions we may or may not have, since we are extending the courtesy of our witness list each and every week. Thank you.
Anything else for the record?
I do. And it sounds petty to bring it up on the heels of that, but I promise it's not correlated. I had asked my co-counsel to address this issue, and he assures me it was a draft, so I believe it was. I just think it's generally disrespectful to be, during questioning, saying Ms. Menashe said that and Ms. Menashe said that. I think we should be better than that. It is appropriate to say on your cross or on your direct or opposing counsel, but it gets really, I think, catty. That's just my personal opinion. I want to put it on the record. Especially, there's a gender issue there too, and I'm putting it on the record.
Okay, well, for the record, we had this discussion,
Okay.
okay? It was outside the presence of everybody, and I thought the issue was resolved. It appears not to be, okay? This isn't personal between the sides. This is putting on a case. Anything else?
After the state order.
Okay. Have a good night.
Thank you.
I did summon the press up here, the press representatives.